I'm going to try to pull up the chat on my phone right now because I won't be able to see the chat when I share the screen with you guys. Give me 1 second. Okay. See.
Hey, Justin, are you recording this?
Yes, I'm recording this, yes.
Oh, okay, because Phoebe said last time we're not allowed to record this for some reason. I don't know if it's in TAs.
Yeah, so you guys aren't allowed to record the TA sessions, but they do want us to record them. So we'll just control the recording. If it does stop and it does change, I'll let you guys know. But yeah, they do want us to record it just for us to save it. 1 second. Just trying to share the screen.
One question Ryan had was, so you're recording it for your own records, but you're not sharing it with the students. Is that correct?
Yeah, that's correct. We're not allowed to. It's like some faculty and some legal stuff that they're not allowing us to share the recordings.
Bummer. Another question Jessica in the chat asked, or was saying, we hope that you tell us how to study for this course and point out important information.
Oh yeah, no, don't worry. When I start in the lecture and I start going through the material, especially the intro lecture, I'll make sure to go over those key points so that we understand how to the best study for this class. My bad, I'm just trying to. Hold on. My bad, I'm just trying to make sure this is not sharing my screen. Hold on. Share. There we go. Perfect. All right, can everybody see my screen?
Yes.
Okay, perfect. All right, so again, my name is Justin, so I'll be you guys' anatomy TA. I'm going to do my best to see if I can go through a lot of these chat questions, make sure I can answer all of you guys' questions about studying for this course, because I know the second lecture specifically, Muffler was going through a lot of material very quickly. It might have seemed a little bit confusing. Don't worry, we'll go through it. We'll make sure you guys learn the material as best as you can. And I'll try to make sure I answer all of your questions as well, because anatomy is a very interesting course to study for, especially if you've never taken it before. And I'll make sure to go over the necessities for you guys.
Hey, Jess.
Yes.
Recording has stopped.
The recording has stopped?
Yes.
Okay, hold on. All right, there we go. All right, so if you guys have any questions, feel free to just, let me know, put them in the chat, interrupt me, I don't mind. As we go through the lecture, I've interspersed some questions throughout the lecture so that we have some comprehension checkpoints so that we're understanding the material as I go through it. You'll see as I put the questions throughout, I'll talk to them, I'll ask you guys a question, and you'll just put the answer in the chat, whether it's A, B, C, or D. And then so you guys can really engage in the material, because I don't want it to be it's kind of like me just lecturing you guys, because you guys get that already from Muffley and all your other professors. So I want to make this as interactive as possible so you guys get the most out of it. So, okay, that's just the faculty. So for the class, so I inputted my name and email. So feel free to send me an email about anything regarding like study materials, regarding anatomy, any types of questions you guys have. I put my email right there. It's joortiz@usf.edu. Feel free to ever send me an email. You guys know when the TA sessions are. Oh yeah, so the TA sessions are always going to be Fridays from 9 a.m. and 5 p.m. for anatomy. Usually it's going to be, yeah, like every week on Friday. And this was just an odd week that it happened to be on a Monday. That's why it's a little bit confusing. I'm sorry about that, but definitely from later on, we're going to have every single Friday. It's going to be anatomy from 9 a.m. to 5 p.m. So for this Friday, we're going to go through lectures 3 and 4. And then today we're going through lectures 1 and 2. So it's going to be a quick turnaround. But this Friday, we will be having another session that's going to be going over lectures 3 and 4, which will be the lectures for this week. All right. Okay, so for studying for this course, so personally, I never used the book for anatomy because I felt like most of the material for the test, or all the material for the test, was coming straight out of the PowerPoints. So you could use the book, I would say, for like supplemental material. I do know some individuals who were very successful in the program that did use the book like on the side to see if like they were very confused about some images, because it's very hard to like picture anatomy like from a 2D image. So like if you have to go look in the book the book goes into some details. It does correspond to the pages in the syllabus that he does have. So you could look into that. But personally, I never used the book because the tests do come out of the PowerPoints. But just because they do come out of the PowerPoints doesn't mean like they're going to be straight off the PowerPoints. What I mean by that is, for example, like if Muffley wants to ask a question on the exam and he's like, okay, so what is going to be the innervation of this muscle? So what's like the nerve supply of this muscle? He's not going to just tell you what the muscle is. He might just put a picture of it. So you have to know what the muscle is. And then on top of that, you would have to know what the actual nerve supply is. So he likes to ask like second-hand and third-hand questions. So just because it's based off the PowerPoint doesn't mean it's coming straight off the PowerPoint, if you guys understand what I mean. So you got to really like understand and grasp the material, because Muffley really does like to ask those critical thinking questions. So what I do recommend, though, is Complete Anatomy. I used Complete Anatomy last year for this class, and I also used it for Gross Anatomy in the spring. But Complete Anatomy is a really great app. I forget how much it was. I think last year it was like a little bit cheaper. It was like $20 or $25, but it's really worth it. I promise. It gives you like this 3D image of the body. You can like use it on your iPhone. You can use it on your computer. It's really, really good when it comes to like pinpointing structures and giving you like a 3D image of what you're actually seeing without actually having to go to like a cadaver lab, right? So Complete Anatomy, I really highly recommend it. Yeah, so that's just a little bit about the course. In regards to study styles, I feel like everybody does have their unique study style. For me personally, when I was going through anatomy, I would like to talk things out with my friends. I would like to like, I would go through the lectures after the class, and I would just like slide by slide, I would just talk things out. I wouldn't want to like memorize the material at first, because I'm like, okay, let me just talk things out before I start writing it down, just to see if I get like a general grasp of the material, right? So I just go through the lecture, just talk through the slides. Okay, this is what he's talking about. This is what he's talking about. And then on the second time through, I would either talk it out some more without having to look at the slide, or I'll write the most important things down. So I really like keen in on what's important, because it's for anatomy. You really have to focus on like not only like the arterial supply and then the innervation. You also have to focus on the attachments and how everything is in relation to other muscles. So we'll be talking about that during this lecture, about like things that are medial, lateral. Those are going to be really like lifesavers on the exams, because Muffley likes to be very critical when it comes to these exams. So for objectives, you guys know the objectives, but so for anatomical position, so I'm going to start throughout this PowerPoint. You'll see I'll have interspersed questions just like how I said. So we'll just start with anatomical position. So for anatomical position, just like how Dr. Muffley has said, it's with your hands straight out. So when your hands are flat out like this, showing your anterior side of your body, that is going to be anatomical position. So anything relative to the anatomical position is going to be correct. So for example, like we said, you're going to have like your arms are going to be lateral to like your pecs, right? So they'll be on the lateral side, so on the outside of your body, right? Same thing with proximal and distal. Proximal means anything that's going to be closer to your midline, right? So for example, your shoulder is going to be proximal to your elbow, right? But your elbow is going to be distal to your shoulder. So you see how I use those two words interchangeably? Proximal is going to mean anything that is closer. So that's why I said the shoulder is proximal or closer than your elbow, right? So anything that's distal is going to be your elbow is distal to your shoulder, right? So that's going to be that. And then you have superior, anything that's going to be on top. And remember, cranial is the same thing as saying superior. So if someone says something is cranial to that, that means they're talking about superior. Inferior, another word for inferior would be caudal, right? So anything that's going to be inferior is caudal. When I think of caudal, I think of tail. So anything that's going to be lower, on the lower part of the body, right? So that'll be inferior. So that's just anatomical position. So same thing with the foot and the hand. So the palm of the hand, most of you guys know this is going to be the palm of the hand. The back side would just be the dorsum. Same thing with the sole of the foot, and then the dorsum of the foot. So, so for cuts or like planes, like he was talking about, so you have three pretty important planes. So I'll just go through them. The first one I'm going to talk about is frontal. So for frontal, that's going to be anything that's going to cut the body from like just like this. So from anterior to posterior. When I think about frontal, I think about the front of the body. You make the cut and you could see the front of the body. So meaning when you do this cut, it's going to be just like this, and it's going to show the anterior part of the body as well as the posterior part of the body. So when I think frontal, I think, okay, I can see the front of the body. So I'm cutting from anterior to posterior or from front to back. So that's frontal. Remember, frontal is the same thing as coronal. Don't get confused because he could use those words interchangeably. Coronal is the same thing as frontal. Sagittal, I think side to side, right? So when you cut the body sagittal, you're going to see the body from left to right. So you can see the left side of the body as well as the right side of the body. So I think side to side. And in transverse, you should think top to bottom or from superior to inferior. So when they cut transverse, you should be able to see the body. Let me put this laser pointer right here. You should be able to see the body from superior to inferior. All right. So those are going to be the planes. So I like to intersperse these questions. These are going to be like comprehension checkpoints. You'll see these throughout the PowerPoints. So feel free to put your answer in the chat. So which plane separates the body from anterior to posterior? I'll give you guys a second. All right, perfect, I see. So B, yes, correct, B. See, you can use the words interchangeably, coronal or frontal. So like I said, I put in the last slide, I only put coronal just to make sure you guys will really understand that those both mean the same thing. So yes, coronal, frontal, when I think front, think the front side of the body. You can see the front, so you have anterior to posterior. Transverse, think top and bottom, superior and inferior. And sagittal is going to be, think of side to side. You can see left and right. So I just input a little section summary for you guys. You feel free to go over it, but remember that axial is the same thing as transverse, which we'll go over. You have coronal and frontal and sagittal. Just a little section summary for you guys I'll be posting just to make sure you guys really understand the concepts here. So again, same thing here, coronal, sagittal, as well as axial. Axial is the same thing as transverse. It's just another word you can use interchangeably, as well as horizontal. So for sections, there's just a few sections. I guess we went over these already. Like we said, transverse, oblique is going to be anything that's going to be kind of like diagonal, and longitudinal. Longitudinal sections are more associated with, I would just say histology, but it's going to be like, just for example, going right across the leg. There's a question. Caudal can also refer to inferior positions. Like superior can also be, yeah. So yeah, caudal is the same thing as inferior, while cranial is the same thing as saying superior. So if something is cranial, for example, like your head is cranial to your feet, right? But then your feet are going to be caudal to your head, right? So I'm using those words interchangeably when I'm talking about them in relation. Yes, that's correct. Can I reiterate what I'm saying about proximal and distal? Okay, so for proximal is going to be anything that's going to be closer to the body. So the easiest way to remember this is like, okay, so start thinking about your arm. Your shoulder is going to be closer to your midline, right? So when I say, okay, my shoulder is closer than my elbow, you can agree with that, right? To my midline, which is true. Your shoulder is closer than your elbow. So instead of saying closer, you're going to say your shoulder is proximal to your elbow. Does that make sense? It's going to be closer to your midline. And I can say the complete opposite as well. Your elbow is distal to your shoulder, meaning it's further away, right? It's just basically saying closer versus further. It's just a fancy word of saying it. It's proximal versus distal, but you're going to definitely use proximal versus distal instead of closer versus further, right? Does that make sense? Okay, and yes, I'll be sharing the PowerPoints with the edits. Yes, I will. Okay, so for the spatial terms, so we have, just like how I said, I just put the hard ones in this little green box, just so you guys don't get confused about which words are interchangeable. So I just like how I said before, superior is cranial, inferior would be caudal. I didn't talk about anterior, but I did talk about anterior. I didn't talk about ventral. So anterior would be the front side of your body, and it's the same thing as saying ventral. So if I say the ventral side of your body, I'm talking about the front side of your body. So ventral is the same thing as anterior, while dorsal is the same thing as posterior. A couple other ones that he went through on this slide is going to be superficial. As you can see, superficial, intermediate, and deep. So superficial just means anything that's closer to the skin, right? So like the skin is going to be very superficial. Anything that's going to be intermediate is going to be just under that, and then anything deep to that would be deep. So for example, if I wanted to say the pectoralis major, which is just your muscle that's out here, is superficial to your pectoralis minor, because your pectoralis minor is underneath, basically. It's underneath your pectoralis major. So you would say your pectoralis major is superficial to your pectoralis minor. But you would say the opposite if you wanted to use the other way around. You would say your pectoralis minor is deep to your pectoralis major. You see what I'm saying? So it depends on which word you use first, but Those words are going to be pretty important to understand as well. So those are going to be spatial terms. Okay, so I input another question here. So the elbow is blank to the wrist. So is it distal, proximal, deep, or inferior? All right, I see, yes. Answer is B, yes. So the elbow, like we said. So I've been talking about the shoulder and the elbow, but it goes the same way for the wrist, right? So the elbow is going to be proximal to the wrist, right? While the wrist is going to be distal to the elbow, right? So very good job, good job. So for the movements, you guys understand like flexion, extension. So a helpful way I like to remember abduction is, or abduction, because sometimes you want to pronunciate the B. Abduction is going to be anything that's taking away. So remember, abduct means to take away, right? So abduction would be take away. So anything that's going to be taking away from the midline would be abduction. If you're bringing it back to the midline, it's going to be adduction or adduction. And then you have internal rotation, which is going to be, for example, like if you want to turn your let's just say you're holding your hands out and you want to turn your hand in. That's going to be an example of internal rotation. If you turn your hand outwards, it's going to be an example of external rotation, as they're shown here, just right here. All right, so for hand movements, you're going to have supination as well as pronation, right? So the best way I like to remember supination is like soup. So like you hand a soup out and you put your hands out kind of like a cup, right? You put your two hands out together, and that's how I remember supination. So you'll never forget supination because think of soup, right? Like how do you hold your soup? You hold your soup out by holding your hands out like that, just like how this person's holding it out right here. And then pronation would just be the opposite, right? So you'll never be able to forget supination if you remember soup for supination. You hold your soup out just like with your hands face up, and then you're going to have your pronation, which is to be the opposite side. So movements, like I said, we went over all these movements. The only ones I guess we didn't touch upon was the hand movements. So I put a helpful pic here so you guys can understand the different movements between the hands. So for hand, like we said, so anything with the hand, you're going to have abduction. This would be abduction of the hand. The easiest way to remember that is that your hand, if you put your hand out, like you just keep it out flat, supine basically, so with your hand face up, and you just bring your thumb up, just like here, you bring your thumb up, it's out of the plane of your hand, meaning you're abducting it. That's the easiest way to remember abduction. If you bring your thumb outwards, it's going to be abduction. Adduction will be going back to the whatever your position, your regular position in your hand, right? So this would be abduction, and this would be adduction. Flexion and extension are going to be self-explanatory. Just this is going to be flexion, this would be extension, and an opposition just means anything that's touching all your fingers, right? So if you could touch your fingers with your thumbs, you're basically opposing them, right? So think about like I'm opposing my index finger, now I'm opposing my middle finger. Those are going to be oppositions, right? And then reposition would just be the complete opposite. So can you go over flexion and extension? What do you mean by that specifically? Oh, you can talk if you want. Lordina?
Yeah, I mean that in terms of the angles, because when he was teaching about that, I did not understand what the angles, like
Okay.
how it decreases the angle and it increases the angle. It was kind of like opposites and stuff like that.
Yeah. So for flexion, like we said, so what he basically meant was just anything that shortens the angle is going to be flexion. So for example, you have your bicep curls. If you bicep curl, you're going to be shortening your angle, which means you'll be flexing. And if you do the complete opposite, if you extend it or you work your triceps, you're going to be using extension, right? It works the same with any other movements in the body. I don't think we have to like overthink it too much because he won't ask you like which one of these is going to be an angle versus like not like increasing or decreasing angle. You just need to know the general concept of flexion and extension. I think that's as far in the depth that we would need to go to. But yeah.
Okay, thanks.
Of course. Gotcha. So again, same thing here. We went through most of these. Elevation and depression, which would be elevation, would be shrugging. Depression would be bringing backwards. You have protrusion or protraction, excuse me. Protraction is going to be like when you throw a punch, like we said. So when you bring your thing forward, or you bring your arm forward, that's going to be protracting your scapula. When you retract, it's going to be bringing your scapula back, right? So when you bring your scapula back, that's going to be retraction. And those would be some general movements. So for the skeletal system, I feel like this is going to be a very high yield slide. You can definitely test on this. I remember seeing this last year. A different professor definitely taught this course. A different professor taught this certain section. But I remember the axial skeleton and the appendicular skeleton being super important, knowing the differences. So for the axial skeleton, think of like anything that's going to be the center of the body. So you have your skull, your entire vertebral column. So everything that's contained in the vertebral column, which is your spine, and your ribs. Those are all going to be part of your axial skeleton. Your axial skeleton. Your appendicular skeleton is going to contain your clavicles, your scapula, and your os coxae, as well as your limbs. Remember, your os coxae is the same thing as your pelvis, your three pelvic bones that are going to be located right here. That would be your os coxae right there. So I know it gets a little confusing, but you have to remember that the clavicles are going to be part of the appendicular skeleton. Even though they're pretty close to the ribs, your clavicles are not part of the axial skeleton. They are part of the appendicular skeleton. So I feel like this is definitely a highlight slide. I would definitely know the differences between the axial and appendicular skeleton. Definitely testable material. So,
Justin, I have a question.
yes.
It was about the sections. So I was wondering if on the exam, if he would ever ask, like, if I wanted to see this, like, what kind of cut would I make? And then my next question would be, what would the oblique cut be for?
Yeah, so I don't think he'll ask you what specific cuts, like I guess would be the best section. He might use it like in a certain like question. He might be like, okay, so you have a coronal cut of a certain section, but I doubt he'll ask you like specifically what is the difference between these sections. But it's very important to know how these cuts are going on throughout the body. And in regards to oblique section, what do you mean by that? Do you mean like how is he going to test upon that, or can you expand?
Kind of. I just mean like what's really the difference between taking a transverse cut and an oblique cut? Like, what is oblique showing you that transverse doesn't?
Yeah, so oblique is showing you a diagonal cut, right? So like if you're going straight diagonal across the leg, that's going to be an oblique section. So I'll give you like more of a deeper cut, I would say. Like you can see the top part of the leg here, as well as the bottom part right here, just on one slide, right? When I'm saying slide, I mean like a slide, like in histology. And this would be a transverse cut where you can only see the flat part of it. Do you see what I'm saying?
Yeah, kind of. Thank you.
Okay, gotcha. Yeah. Okay, so for bone types, I inputted a couple pictures here just so you guys can understand like what these specific bones were. So for long bones, you're gonna have, like we said, anything that's just long, like long bones, like your humerus and your femur. Your femur is just gonna be your thigh bone, and your humerus would be just the bone in your arm. So I inputted one of these bones. These are just gonna be the different bones that are going to be examples of long bones. You have short bones right here. These would be the tarsals and the carpals. So this is going to be an example of the tarsals or the carpals. Those are going to be very short bones, very small bones, right? So they're just going to be looking like kind of like squares. That's the way I think of them. They're very short bones, but it's important for us to realize the differences between these bones because I feel like it's definitely another testable topic for him to ask upon. You have flat bones. Flat bones is going to be anything that's obviously flat, right? These names are self-explanatory. So the scapula is going to be right here, just like how I show. It's considered a flat bone. You're also going to have the ilium, which is actually right here. This is the ilium, which is going to be part of the os coxae, or the pelvis. It's going to be another flat bone. And your frontal bone, which would be right here, this would be on basically on your forehead. It would be another flat bone. You have irregular bones. Irregular bones are going to be anything that's irregular, like out of the ordinary, right? Like, so your vertebrae is very like an irregular bone, right? It's not common. No bones in the body look like that. And you have your sphenoid. Your sphenoid, which we'll talk about later, which is like the butterfly bone in your brain, but it's very irregular as well. And sesamoid is going to be a very interesting bone. You actually have sesamoid bones are mostly going to be bones that are located inside a tendon. So for example, the patella, which is located right here, is going to be considered a sesamoid bone, which would be located in the patella tendon. So here's another comprehension check question so that you guys understand what's going on. So which one of these is not part of the axial skeleton? Remember, not part of the axial skeleton. So feel free to put your answer in the chat. All right. Nice. C, yes, you got that right. I tried to trick you up a little bit, but you guys did get the question right. Sacrum, remember, the sacrum is still part of the vertebral column. So for the vertebral column, which is the entire spine, you're going to have the cervical vertebrae, the thoracic, the lumbar, the sacrum, as well as the coccyx. So it's important for us to realize he's not going to just throw in there and be like, oh, vertebral column, because that's straight off the slides, right? He might want you to think a little bit deeper into that and he might throw sacrum or coccyx. So, and you'll be like, oh, I haven't seen that word in the slides. But remember, those are all part of the vertebral column, right? So just because he puts sacrum doesn't mean he's not talking about the vertebral column. But yes, you guys stuck to your guts, and os coxae is right. That's going to be part of the appendicular skeleton. Very good job. Okay, so for skeleton, you're going to have long bones. So just long bones. You have spongy bones, which are going to be located right here on the epiphysis. You're going to have the compact bone, which would be the very hard bone surrounding the medullary cavity, and the medullary cavity is going to be containing your bone marrow, right? But obviously, as you age, your bone marrow will turn into adipose tissue or fat tissue later on, mostly in the diaphysis. You'll have some left in the epiphysis. But when I think of epiphysis, think of ends, like both ends. So your epiphysis of your bone is going to be at the ends of your bones, right? So epiphysis, think at both ends. For diaphysis, that's just going to be just in the middle, right? So again, your epiphysis, this will be your proximal epiphysis, meaning closer to your body, because this is going to be the femur, right? So this is your leg bone. This is going to be closer to your midline, right? So this is why it's called proximal epiphysis. This is your diaphysis, which is going to be the middle of your femur, and this will be your distal epiphysis, meaning further away, right? So epiphysis, remember, think both ends. So for bony features, I highly doubt he's not going to ask you on an exam, be like, which one of these is associated with a joint or which one of these is associated with a tendon. But it's very important to understand that, like, when he does go through these lectures, he's going to talk about all these names. Like, he's going to talk about, for example, like the greater trochanter. He'll talk about the linea aspera. He'll talk about like anything that's associated with the spine, the iliac spine, the tibial tuberosity. Like, a lot of these names are going to be attachments for bones. So he wanted to put this out here just to make sure that you guys are aware that there's a lot of names that are going to be associated with how muscles attach to bones. And it's going to be very important for us to get these words down later on. But I doubt he's just going to ask you what's the difference between a spine and like a linea, right? He's just throwing it in there so you guys are going to get used to those words. So,
hey Justin.
Yes.
I have a question. So for some of the slides, like the slide with like the skeletal system and like the bone types, you're saying that those are like high yield for the test. But when Dr. Muffley was going through the PowerPoint, at least for this one, he was saying like, oh, this is just kind of a lot of introduction, that like we're going to go through all of this like throughout the entire course, like for the semester. So which of the slides, like specifically, do you remember like that these were on the first test that we should like make sure that we know, versus just like being familiar for like understanding his lectures like throughout the semester?
Yes, so I'll definitely try to point those out throughout the lecture. Last year, we actually had a different professor teaching this intro lecture. So Muffley, I don't know what he's specifically going to test on with this lecture because he didn't teach it last year. But I'm definitely going to hone in on the things that I think that he will test on, because Muffley, I know the type of questions Muffley usually asks. So I'll definitely tell you which ones I feel like are going to be more likely on the exam, and I'll tell you the ones that you can kind of like brush over a little bit more. So I'll try to be a little bit more specific when it comes to those questions, but I'll definitely emphasize those throughout the PowerPoint.
Okay, thanks.
Justin, I've got one more question too.
Yeah.
Just to gauge for future PowerPoint. So going back to that slide, please.
Oh,
details like bone marrow turning into adipose tissue. Are those the kind of details that we could expect and kind of need to dedicate some effort to?
So
are we just really kind of?
Yeah. So I don't know. He's not going to ask you on the exam, when does hematopoietic tissue turn into adipose tissue? He's just saying that, like, basically he wants you to understand what the medullary cavity is. So he's giving you an example like, oh, the bone marrow is inside of the medullary cavity. So you understand what the purpose of that is. But other things that he does go through the PowerPoints that he does expand upon a little bit that I feel like that would be a little bit more high yield, I will definitely tell you guys. But I don't think he's going to ask you going from hematopoietic tissue to adipose. That's just like fun fact type of stuff. Answer your question?
Yeah, I appreciate it. Thank you.
Gotcha. All right, so.
Sorry, I had another question. Does process really just mean anything that's like jutting out, like the spinous process? Like, I just feel like, what does process really refer to? Because we use it so often.
Yeah, so just like how they said here, processes, I guess, is just another name. Like we said, like spinous process will be something that's coming out of the spine. Your transverse process will be something that's coming out of the transverse process, out of the spine as well. So processes are it's just a name that they put for associated with some of the joints that are going to be attached to. I don't think we have to like look too deep into like why they're using the word process, but we'll go through that more into the back lecture when we do have some of those words that are associated with processes, and you'll be able to tell the differences in that when we go through those.
Okay.
Okay, sounds good. So here's another comprehension check question. So which bone is a flat bone? The patella, the carpos, the sphenoid, or the ilium? Yep, most of you guys put D, and that is correct. The ilium. The ilium is going to be a flat bone. So I just inputted the picture here just so you can see. This is the ilium, which is part of the pelvic girdle, also known as the os coxae. You're going to have the ilium, the ischium, and the pubis. You'll talk about those later. Those are going to be the three bones that are associated with the pelvis, but the ilium is definitely a flat bone. Good job. Really good. Good job. So for joints, you're going to have, so he goes through 2 slides talking about joints. So this is going to be the first slide talking about joints. This is joints based on what the cushioning is of the 2 articular joints. The next one we'll talk about is another different way of looking at joints, but this is talking about the cushioning of the two articular joints. So when I think of fibrous, I think of firm, right? So think of firm, like very little movement. You have your skull sutures, right? So anything in your head, your skull sutures are going to be your fibrous joints. Cartilaginous, like we said, are going to be more so associated with your synovial joints. So for example, your knee joints and other joints common to those. So when I think fibrous, think firm. Yes, and that'll be it for this slide. So for the next slide, you're going to have, these are joints based on what the mechanics are of the two bones. So I feel like this slide is definitely a little bit more high yield. I think Muffley might ask a question maybe on one of these, but I doubt he'll go outside of this and be like, okay, which one is the knee joint an example of a hinge joint? I mean, he's not going to go outside of saying the elbow joint, because that's the only thing he talked about during class. But I would definitely look into some of these joints to understand the differences. So I'll go through them one by one. So that we understand that. So ilanoaxial, so that's going to be the first joint, or that's going to be the joint between C1 and C2. So the cervical vertebrae 1 and cervical vertebrae 2. That's the joint that allows you to go no, right? So that's the joint that allows you to go no, so it allows you to go left to right, so side to side. When you pivot your head, that's your ilanoaxial joint. The best way I like to remember that is like, that's going to be your AA joint. So A, like when you talk to somebody and you're like, A, like it's kind of like you're going no. We'll talk about more in the back lecture when we talk about the ilano-occipital joint, which is going to be your AO joint. We'll talk about the differences with that. But the best way to remember the ilano-axial, I think of AA, so it helps you pivot, making you like that no face. You're going to have the hip joint. That's just going to be a ball and socket. So your femur has like this ball. It's going to go into this acetabulum, which is just a socket in your os coxae. Then you have plane joints, right? So plane joints are kind of going to be like joints that like have very little movement, but they kind of do like some little sliding actions. That would be your acromioclavicular joint. So think about it like it's between your acromion and your clavicular, or your clavicles, right? So your acromion, which would be right here, and your clavicle, which would be right here. Remember, your clavicle is part of your appendicular skeleton. Remember, it's not part of your axial skeleton. And then you have that's going to be your acromioclavicular. Elbow joint, so anything that's hinged, I think of like door hinge, like anything that's door hinge. Your elbow, like we said, is going to be a hinge joint that allows just uniaxial movement. And then these two are going to be a little bit I guess harder to understand, but carpal metacarpal joint is going to be a saddle joint. So when I think of this, you have to understand how the hand is like made up. So first you have the carpals, and then you have the metacarpals, and then you have the phalanges. So we talked about the carpals as like the short bones right here located on the bottom of your palm. And your metacarpals will be extending throughout your palm. That's going to be what makes up the base of your fingers. And then your phalanges will actually be your fingers, right? It's actually in alphabetical order. That's the way I remember it. So C, M, and then P. So carpals, metacarpals, and then phalanges. So when he's talking about carpal metacarpal joint, he's talking about literally the carpals between the metacarpal. And specifically, he's talking about the first metacarpal. So that's your thumb, right? So that's going to be a saddle joint. Think about it. Your thumb can do lots of movements. Like your thumb has like almost unlimited range of motion, right? So your saddle joint is going to be your carpal metacarpal joint in your first metacarpal. That just means your thumb. That's just going to mean your thumb. So that's going to be at the base down here, which is going to allow you to like throw your thumb like in circles, abduct, adduct, etc. Condyloid joint, on the other hand, allows a lot of movement, but not as much as like a saddle joint. So for example, this is talking about metacarpal phalangeal. So if we think about this, we're like, okay, so this is from metacarpals to phalanges. So we already skipped the carpals. So we're talking about like the knuckle joints. So your knuckles, like we said, are going to be your metacarpals to your phalanges, right? So your phalanges will be your fingers, and your metacarpals will be extending on the palm of your hand, right? So for metacarpal phalangeal joint, you know that your index finger, for example, at your knuckle has some movement, right? It has some really good movement, but not as much movement as your thumb, right? So that's the way I think about it. Condyloid has a good amount of movement, but not as much as your thumb, which would be a saddle joint. So again, it's important to know the differences between those, because I feel like he could just throw in a question on there on the exam. So I just inputted another image here. I just added this slide just to help you guys really understand the differences. Remember, it's in alphabetical order: carpals, metacarpals, phalanges. So carpals, which is like the short bones. Remember, we talked about these. These are the short bones. They're kind of like rocks, right? So these would be your carpals. Then you have metacarpals, and you have your phalanges, right? So this would be the carpal metacarpal joint of the first metacarpal, right? So this is the first metacarpal, second, third. This means like thumb, index finger, middle finger, etc., right? So this is the joint they're talking about. This is the saddle joint. That's going to be your thumb, right? So that's going to be the saddle joint, your carpal to metacarpal joint, the one that allows you to have like unlimited motion. And this is going to be your metacarpal phalangeal joint over here, 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 etc., right? Those are going to be your knuckles, right? Those are going to be your knuckles, and that's going to be your condyloid joint. Allows for a lot of movement, but not as much movement as your saddle joint, right? So for muscle types, we had another professor that talked about this last year. It was very low yield. They didn't ask any questions on that, but knowing that Muffley's teaching this lecture, I wouldn't put it past you. but I wouldn't make this like the highest of yield stuff to look at. I would look at this like kind of like maybe before the exam, just look at this and be like, okay, let me just know the differences just in case he asks on it. But this is definitely not the highest yield of stuff of information. He could test on it, which is why I said that like I would look at it just like once before the exam, maybe twice, just to make sure that if he does talk about it, we do understand. But it's definitely lower yield. It's not the highest of yield. But look at this one a few times just to see the differences, but I don't think it's the highest of yield. So for muscle attachments, you're going to have, like we said, so I put right here in the notes, you're going to have tendons. Hold on. Oh, yeah. Okay. I'll speak slower. I got you guys. I'll speak a little bit slower, but I will be posting these PowerPoints on the Canvas so you guys can look into these afterwards, but I'll definitely speak a little bit slower then. Okay, so for tendons, so your tendons are going to be connecting your muscles to your bones, right? Your ligaments are going to be connecting your bones to your bones, right? So for example, your ACL, that'll be like your anterior cruciate ligament. That's connecting, for example, your tibia to your femur, right? That's going to be an example of a cruciate. That's going to be an example of a ligament, right? Ligament, bone to bone. So tibia to femur. That's going to be an example of ligament. Tendons, like we said on the other hand, will be anything that's going to be muscle to bone, right? So for example, your bicipital tendon is going to connect your biceps brachii to, for example, your ulnar, or one of your bones in your arm, right? That's going to be the difference between tendon and ligament, right? And again, he emphasized a little bit about the proximal and distal. Proximal is going to be in red, meaning that's going to be the proximal attachment, the closest attachment, and then the insertion or distal would be in blue. So I guess that's just a little fun fact. So I inputted another comprehension question. So which one of the below is a condyloid joint? Remember, we talked about condyloid joints. Is it going to be the metacarpal phalangeal joint, the atlantoaxial joint, the carpal metacarpal joint of the first metacarpal, or the acromioclavicular joint? This one's a little tougher because the joints have such long names, like sheesh. Okay. So yes, the answer is A. So the A, condyloid joint. So I inputted another image right here just to help you guys really understand. These are going to be the carpals, so like your short bones, right? These are going to be your carpals. These would be your metacarpals, right? Metacarpals right there. And these would be your phalanges, right? These are going to be your fingers. Condyloid, like we said, is going to be anything that's going to be right here, anything that's metacarpal to phalangeal, right? Those are going to be your condyloid joints. Over here would be your saddle joint. This is going to be your carpal metacarpal joint of the first metacarpal, right? So again, like we said, your saddle joint is the thumb. Think of thumb. It has unlimited movement. Your acromioclavicular, that's a plain joint. That's going to be located right over here in your clavicle and your acromion. So it allows very little sliding movement, right? And you're going to have your atlantoaxial joint. Remember, that's your AA. Like AA, that's going to be like your no. So it allows you to pivot. That's your pivot joint, right? So just to go through those a little bit.
Hi, Justin. Can you expand on the difference between the condyloid and the saddle joint again? Like
Yeah.
a distinction?
Yeah, I got you. Hold on. Do this real quick. So let me get my laser pointer. So honestly, it's just differences in shape, right? So condyloid is just going to be, it's easy if I show you guys on the slide before. So condyloid, like we said, is going to be, it's kind of shaped like this. So it's these two things that are going to be, it's just the shape of the bones, how they articulate. Like you said, they allow like bilateral movement or biaxial movement for condyloid, but it's not going to allow you to move as much because this is a saddle. The saddle is just shaped in a way that allows your thumb to go back, forth, and all over around your hand. So it's just basically just the differences in the shapes. That's what they're talking about with joints. Like when they're talking about saddle, they're just talking about, okay, this is actually obviously a concave with a convex, but they're just going to call it a saddle joint because that's what they call it, and that's just meaning that it has the most movement, right? So when they're talking about the differences in these joints and like different names, they're just corresponding to what kind of movements these joints can have, right? So condyloid is just another name or a different shape of the joint because they're like, oh, this is kind of like the saddle joint, but it doesn't allow as much movement, so we gave it a different name. You see what I'm saying? So it's called condyloid joint. It's not going to allow as much movement as the saddle joint because this allows for more range of motion, but it's definitely going to allow for a good amount of range of motion. You see what I'm saying?
Yes, thanks.
Okay, gotcha.
Justin, I have another question about that as well.
Yes.
Going back to the like fibrous and the cartilaginous, I think is how you pronounce it.
Yeah.
So would all of the joints on like the slide below that with the skeleton, would all of those be the cartilaginous ones since they like are more involved with like movement and stuff?
So, like, for example, this would be like a cartilaginous joint. Well, this is just the same thing, but this would be an example of a cartilaginous joint. But for fibrous, like we said, he said skull sutures. So this right here would be an example of a fibrous joint, right?
Right, but the slide below that one.
Just, you talking about these?
Like the next slide. Sorry.
Oh, sorry, yeah.
Yeah. So are all of those joints considered the cartilaginous ones?
Yeah, these would be cartilaginous joints.
Okay,
yeah.
Perfect. Thank you.
Gotcha. Okay, so we went through that one. So for contractions, you're going to have isometric, concentric, or eccentric. So I wrote a little note right here so you guys can know the differences, but isometric is going to be something that's increasing tension, but there's no movement. So if you have your arm out just held onto the side and you're just holding it there, that's going to be an isometric contraction, right? So obviously it takes some work to hold that muscle there. But the muscle is not shortening, and nor is it elongating, right? Eccentric, on the other hand, is going to be if you're holding your arm up there for so long, you can't hold it anymore, and it just keeps going down, down, down because you can't hold it. That's going to be eccentric contraction, right? Because you're going to be lengthening your muscle as you're bringing it back down. This is going, for example, let's say this is your deltoid muscle, right? That's going to be eccentric. Concentric will just be the example of raising up your arm, right? So if you want to raise up your arm, you use your deltoid muscle to abduct to bring your arm up, right? So that's going to be concentric. If the weight is too heavy, or if you can't hold your arm long enough and your arm starts going down, 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 that's going to be an example of eccentric because your muscles are lengthening. And an isometric, like we said, is going to be just increasing tension but no change in length of the muscle. Circulatory system, don't memorize this. We'll go over it eventually, but you're not going to have to memorize this. Nor with the lymphatic system. He touched a little bit upon the nervous system. I would just briefly look in this slide, but I feel like most of us know like this is the central nervous system, which would be like the brain and spinal cord. The peripheral nervous system will just be everywhere else, right? So under the peripheral nervous system, you'll have the somatic nervous system. That just means, like, for example, if I want to move my muscles, voluntary movements, like I want to lift weights or whatever, that's going to be your somatic nervous system, right? Your autonomic nervous system is anything that's happened like involuntary. So for example, your heart beating, your peristalsis in your intestines, meaning like your intestines like moving the food along, right? Those are all involuntary things. Like we can't control that, right? That would be autonomic. And your autonomic will break up into your parasympathetic and your sympathetic. Sympathetic would be like fight or flight, like you said, like it's going to be like your fight or flight responses, and your parasympathetic, I think of like rest and digest, right? So these are like complete opposites. You won't have to memorize this. He's not going to ask you the differences between all these specific vertebrae. So for dermatomes, I guess it was a little bit confusing when he talked about it in class, but I wrote a little note here. So a dermatome is an area of skin in which sensory nerves derive from a single spinal nerve root. So the example that he gave in class was, for example, if you have numbness in your shoulder, right? So for example, let's say this is C4, right? This is going to be a C4 dermatome. So if you have numbness in your shoulder and you find that out on like a skin test, you might be able to locate that to being C4 damage at the spinal nerve level. Spinal nerve meaning at the vertebrae, right? So you have these certain dermatomes, which is basically like, so you have the spinal nerves that are coming all out of your vertebral column, right? These spinal nerves actually have branches of sensory nerves that are all over throughout the surfaces of your skin, right? So example, like we said, if I touch my shoulder, I'm actually going to have some connection between, like we said, the spinal nerve of C4, right? So that can be indicative of some spinal nerve damage. So that's what dermatomes are. I wouldn't memorize this picture right now, but he does put some dermatome pictures later on that I would definitely memorize because I remember him testing something about the differences between these certain ones in the limbs. But right now, you won't have to know about that. But I think he will definitely talk about that later on. And then this is a little bit different. Peripheral nerves are derived from several spinal roots. So dermatomes derive from a single spinal nerve, while your peripheral nerves can derive from several spinal roots. So for example, your brachial plexus, which is going to be, like you said, a plexus of nerves that come across your arm. Those are going to be, for example, derived from bunches of spinal nerves. So he gave the example, the radial nerve, which comes off your brachial plexus. That comes off, that comes from C6 to C8, right? So just because you damage C6 doesn't mean you're going to lose your entire radial nerve, right? You won't lose the entire innervation of your radial nerve just by damaging C6. You might have some diminishing aspects of it, but you won't lose the entire thing of it. So that's the differences between peripheral and dermatome. And this is just a summary slide. So if you have any questions, I'll give you guys like a 5-minute break, and then we'll definitely go into this back lecture because this back lecture is going to take a little bit of time, and I want to make sure we get through everything adequately. But if you have questions, shoot me. We'll start again at 9:50. So we'll start again at 9:50 just to give you guys a little bit of break.
Hey, Justin, I'm a little confused between the dermatome and peripheral nerve. So dermatome specifically refers to the skin area, which is from a single spinal nerve, and the peripheral nerves are talking about the deeper innervations, which can be combinations of several nerves. Is that the difference? One is skin and the other is muscle?
Yeah, that's basically the difference. Yeah, so dermatomes will be anything that's on like the skin surface. That would be coming from a single spinal nerve, and then the peripheral nerves, yes, will be coming from multiple spinal nerves.
Okay, so if he were going to ask a question about the differences between peripheral and dermatomes, it would have to be very clear as to whether or not we're talking about the skin versus innervation function of the muscle.
Yeah, yep.
Okay, thank you.
Yep, gotcha. Yeah, feel free to ask me any questions. We'll start again at 9:50, but if you guys have any questions, let me know right now. But I'll give you guys like a little bit of break.
Can you go back to the dermatome slide?
Yeah.
Wanted
to. I'll be posting these slides as well, just so you guys. I know you guys want to write them down right now, but I'll be posting them after the 5 p.m. session today, as well.
Hey, Justin.
Yeah.
For the exam, when he does post pictures, were they mostly from the Ackland tapes that he was talking about?
So pictures, he talked about this. Wait, can you turn your mic off? Sorry, I hear like some echo. Thanks. Okay, so he talked about this, like in the intro lecture, that he will be posting some cadaver pictures. Last year, he didn't have any cadaver pictures on the PowerPoints. More so, I think, because we were allowed to go to the gross lab. So we did see cadavers like before the exam, so we were able to see them in person. But this year, obviously, due to COVID and stuff like that, it's a little bit different. But he said that he will be testing upon that. So I did input questions on the next PowerPoint from the back lecture about, we said certain cadaver pictures in relation to what muscle they innervate or what the muscle is, what the innervation is in arterial supply. Because I think since he did bring it up in the lectures, he definitely will test upon those cadaver pictures. So yeah, those are definitely going to be some high yield images, but he won't be coming out of like the Ackland tapes, You won't have to worry about, oh, I need to go watch all these Ackland lectures because he might pull out a certain picture from it. No, he specifically said that he's going to use only the pictures that he used from his slides. So that's going to be sufficient enough for you to study from. Does that make sense?
Yeah, thank you.
Okay, cool. Okay. If there's no more lectures or no more questions on this lecture, I'll pull up the other one. Give me a second. But we'll still start at 9:50. Oh yeah, and let me know if like you guys want me to slow down or anything. Like I'm here for you guys. Like I want to make sure like you guys have the clearest amount of material. Like you really understand what's going on. And if you need me to slow it down, sometimes I know I speak a little bit fast. And if I do need to slow it down, let me know. If you want me to expand upon something, let me know. I'm here to make sure you guys really understand the material because anatomy is a tough topic, definitely a tough material. So I want to make sure you guys really understand what's going on. I'm going to unshare really quick.
Hey, Justin, I have 2 quick questions.
Yeah.
First, the level of questions that you're asking us in the middle of this lecture are kind of like level 1, very basic questions, or are those the type of questions that he would ask?
Those are mostly, a lot of them are level 1 questions, I would say. They're just trying to make, it's like, those are like recall questions. He will throw some recall questions on the exam, but most of them are going to be critical questions, I would say. Like, for example, he might just ask, what's the innervation of this muscle, right? And he'll put a picture of it. That might be, actually, that would be like a two-level question because you have to look at the muscle and then understand the innervation. But for example, he might be, what's the innervation of the latissimus dorsi? Then that would just be a one-level question. He might throw like a few of those on the exams, but he's definitely more commonly going to throw critical questions on the anatomy exam because he wants you to like understand anatomy, not just like memorize it. You know what I mean?
I got you. Second question, regarding the exams. So did your class, like the majority of the class, say 10%, 20% get A's on the first exam, all the exams? Like how are the performance on the exams? Like did he curve at any point or was that at the end like other classes? Like how is that going to go?
Yeah. So he didn't curve. I don't think he curved in anatomy. But the anatomy first exam was definitely very hard. So I would not sleep on any of this material because the material does get very difficult as we go on. The back, as you'll see, it's going to be a little difficult lecture, but as you keep moving on throughout it, it just gets harder with like learning to brachial plexus and going throughout these things. So I would definitely put a lot of studying into anatomy for the first exam because Muffley is one of the professors that likes to ask very difficult questions. I'm not even going to lie, like his questions are pretty difficult. So you want to make sure you really know the ins and outs of this material. In regards to Average. I think the average was, I don't remember. It wasn't too high. But I think, I don't know. I think it was like an 80 something. I think was the average. That's going to be normally your averages, I think, throughout the classes. That's how it was last year. It depends on which class you're taking. In the spring, the averages will be much different because they curve. The classes are much harder, but they curve a little bit more in the spring. The fall, they don't curve as much.
Okay, so for instance, how it's going to go is you take the exam, your exam score is not visible, they review the questions, and then they do whatever they're going to do, and then release the scores where the average is usually at least a B.
That's correct.
Okay, thank you.
Yeah. Okay. All right, let me share my screen again. All right.
Justin, you also have a question on the chat on the side there.
Oh. Hey, can you read it? What'd you say?
It's Tara Dahl's question. It said, do you think using Anki will be appropriate to study for this class?
So just like how we talked about in the study sessions, I feel like everybody has their own studying style. Personally, I never used Anki, but one of my closest friends in the program did use Anki. He would just input all of his flashcards or whatever, put all the structures and put in the innovations, arterial supply on Anki, and he felt like it was very beneficial for him. For me, it felt a little time consuming to do Anki, but it's honestly a personal preference at that point. So I would try it at first. If you feel like it works, use it. If it doesn't work and you feel like it's too time consuming, I would hop on to something else. That's what this program is really about, is trying new study styles to see which one works best for you guys. Makes sense? All right. Can you guys see my screen?
Yes.
Yes, okay. All right, so it's 9:51. So we're going to start with the back lecture. So I know Muffley flew through this lecture, and I'm going to make sure that we guys really understand the lecture. Tell me to slow down. Ask me questions if you need anything. I'm here to help you guys to make sure that you really understand and get a grasp of this material. So for the back, so we'll start with this. So bony support, that's just the vertebral column. We'll talk about the musculature, and we'll talk about the function and the movement of the back. So the most important thing on this slide, I would say, let me get my laser pointer out. So the most important thing on the slide is going to be knowing that the vertebrae is going to have, there's 33 vertebrae. So 33 vertebrae, so I inputted this on another slide. There's 33 total vertebrae. It's going to be broken up as in 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccyx. But remember, the sacrum, it's fused, obviously. So obviously, you're not going to be able to point out the 5 sacral ones, and the coccyx are fused as well. But just know that there's going to be 5 and 4, and then those are variable. But in total, you're going to have 33 total vertebrae. Let's see. Okay, so so this is going to be the basic picture. Excuse me. This is going to be the basic picture of the vertebrae. So you're going to have the body, right? So this is going to be the body, which is just going to be the vertebral body. You'll have the pedicle. So the pedicle is going to connect the vertebral body to the transverse process. You see that? This is the pedicle. The pedicle is going to be connecting the vertebral body to the transverse process. Remember, the transverse process, the thoracic transverse processes are going to connect to the ribs. We'll go over that later. You have the pedicle connects the vertebral body to the transverse process. Your lamina, like we talked about, lamina, like we said, you actually do laminectomies and some surgeries in order to expose the spinal cord, right? You expose the spinal cord, you can remove the laminas or cut them out to expose the spinal cords. Your lamina is going to connect your transverse process to your spinous process, right? You see that right here? And then you're going to have your vertebral foramen. Your vertebral foramen, remember, is going to have your spinal cord. So your spinal cord goes right through the vertebral foramen. We'll talk about other foramens as we go on throughout the lecture, but remember the vertebral foramen is going to have the spinal cord, right? And then superior articular facet, that's going to be connecting to the adjacent vertebrae. So when I'm talking about articular facets, I'm talking about things that are going to connect, well, specifically for the vertebrae, to the next vertebrae. So for example, let's just say this is vertebrae 5, right? This is the 5th vertebrae that has the superior articular facet, right? So the superior articular facet of the 5th vertebrae connects, think of it like a vertebrae on top of this, connects to the inferior articular facet of the vertebrae above, which would be the 4th vertebrae, right? So we'll go through that. Don't worry, we'll go through that more as we go into the lecture. So we really hone in on those details. So here's a little section.
I have a quick question.
Yeah.
For things like the laminectomy that aren't necessarily on the slide, but he takes the time to talk about it, are those things we should know?
I think that's more so like a fun fact. There are things that he does talk about that aren't on the slides that will definitely be tested material, but I think that's more so like a fun fact.
Okay, thank you.
The reason why he said that is because he wants you to remember that if you do a laminectomy, you can expose the spinal cord, and like if you won't usually you don't cut the pedicles, right? So if you cut the pedicles, you have a very high chance of severing the spinal cord. So you don't want to cut the pedicles off. You usually cut the laminas because they're further away. But that's just like a fun fact.
Another quick question about this slide was, is the neural arch the same as the lamina? They look to be pointing at the same thing.
So the neural arch is just this circle thing. It's not shown here. That's going to be connected around the entire vertebrae. So it's containing like the pedicle and the lamina. So I would think it's just associated like that. You don't need to know, like, he's not going to ask you the subtypes of the neural arch. Just know that the neural arch is just this thing that wraps around. It's not showing, but it's actually wrapping around right here.
How much of Latin are we supposed to know for this? For example, would we on a test, would the vertebral body be referred to like the corpus vertebra, or are we good with just knowing vertebral body?
You're good with just knowing vertebral body. He's probably just going to say vertebral body on the exam if he was to talk about it. I'll let you know if there's anything else that he'll use like other words for. So I'll try to expand on those as well.
What kind of questions will he ask for this? So will he ask like, oh, what connects the body in the transverse process, or can we not expect those kind of questions? Or would he show a picture?
So as we go throughout the PowerPoint, you'll see what's more associated with that, because we'll talk about the lamina. It's important to know the lamina, obviously, because eventually we'll talk about the ligamentum flavum, which is going to be connecting all the laminas. And it's important, like, these are like the basic necessities of the vertebrae as we go throughout the lecture. So, I mean, he might ask a question on it, but I feel like it's more important to understand where these structures are so you can understand everything about the vertebrae, because there's going to be lots of parts to this that we'll go through throughout the PowerPoint.
Okay, thank you.
Gotcha. Okay, so I put a little section summary here. So it's going to be the lamina, like we said, connects the transverse process to the spinous process. So transverse process, those things that are poking out to the side, right? That's your transverse process. Connecting to your spinous process. This is your lamina right here, your lamina. Your pedicle connects your vertebrae or your vertebral body, right, to your transverse process. So that'll be right here. So I just inputted a little picture right there. So for vertebral column, so we talked a little bit about this slide. So I talked about this in the first slide again, is that you have the superior articular facet and the inferior articular facet. When I think of articular for specifically the vertebrae, I'm thinking about attaching to certain, like the other vertebrae. Because later on in the slide, he'll talk about superior and inferior costal facet. Those are going to be attaching to ribs. We'll talk about that later on. But when I think costal, I think ribs. So when you think articular facet, think adjacent vertebrae. Okay. So the superior articular facet, let's just say, for example, like I said, this is the fifth rib. The superior articular facet, which is located right here, attaches of the fifth vertebrae. Attaches to the inferior articular facet of the fourth vertebrae. Does that make sense? So basically, this is going to be what they so-called the zygopophysis, I can't even pronounce, zygopophysis joint, or the facet joint, synovial joint, just a fancy way of saying that. But it's just going to be a joint that has very limited movement, right? So again, it's really important to know that the superior articular facet of one vertebrae attaches to the inferior articular facet of another vertebrae. This would be right here. These little holes are going to be called intervertebral foramens, right? So what comes out through those are going to be your spinal nerves. So your spinal cord goes through the vertebral foramen, which is straight down, right? It just goes straight down. But your spinal nerves come out of this. They're like poking out, right? So your spinal nerves are poking out. You're going to have your ventral branch and your dorsal branch. We'll talk about those more when we get later into the back. Yes. And then, yeah, this is going to be the intervertebral disc. You'll have the cartilaginous part, and you also have the gelatinous part, which is going to be the center part of the intervertebral disc. So here's a comprehension checkpoint. So which vertebrae have transverse processes that attach to the ribs? Is it the cervical, thoracic, lumbar, or all of the above?
I have a question. You said gelatinous joint. Where is that on the picture?
So yeah, I didn't mean gelatinous joint. What I meant is that, so for example, for the intervertebral foramen, you have this thing that's called a nucleus pulposus, which just means it's like the center of the, inside of this like gray part right here, you have like some sort of like gelatinous material, which is called the nucleus pulposus. And what's surrounding that is called the annulus fibrosus. You don't need to know that, but the annulus fibrosus, which is surrounding the vertebral, surrounding the IVD or the intervertebral disc. For example, if you rupture your disc, what the liquid that's coming out is like that gelatinous liquid, your nucleus pulposus. That's what I meant by that. What's inside of that IVD or inside of this intervertebral disc. Does that make sense?
Yes.
Okay. So yeah, which vertebrae have processes that attach to the ribs? You guys said B. Yes, B. So the thoracic vertebrae is going to be, the thoracic vertebrae is going to be the only vertebrae that have processes which are going to be like holes, I guess. Yeah, things that are going to attach to the ribs. Yes, correct. Great job. So he talked a little bit about the vertebral column. He talked about the anterior longitudinal ligament, which is going to be the front side. So if you think about the front of your body, that's going to be the front side of your spinal cord. The posterior longitudinal ligament is going to be just behind the vertebral body, right? So it's going to be located right here. This is your posterior longitudinal ligament. It's not shown, but it's going to be located right here. Interspinous ligament, I think, okay, in between spinous processes, right? So this is going to be in between each of these spinous processes is an interspinous ligament. So in between the spinous processes, you have an interspinous ligament, right? Your supraspinous ligament is just going to be this thing that's going on the posterior side of your spinous processes. So it's just going right down your back, basically. That's your supraspinous process. So, and this again is going to be your zygapophysis joint, which is going to be between the superior articular facet of this vertebrae and the inferior articular facet of this vertebrae, right? And then these will be your intervertebral foramens, right? Intervertebral foramens. You see these spinal nerves, right? So the spinal nerves are coming right off the intervertebral foramen. You have your ventral root and your dorsal root. We'll talk about those more later. I just inputted the picture right here. So this would be like the spinal cord going down this side, and these will be the spinal nerves coming out. So you can see them right here. We'll talk about this, the ventral and dorsal, as we get later on into the lecture. So we have the vertebral column right here again. So helpful tip I put right here. So ligamentum flavum is going to connect to the lamina. So like I said in the first slide, yes, it's important to understand like all these structures, but like we said, we're going to get more into these, what connects to what. So it's very important to know where the lamina is, where the pedicle is, spinous process, transverse process, etc. So this would be your ligamentum flavum, right? So this is connecting your lamina right here to your next lamina, right? So this is basically just a cutoff of this picture right here. This is the back side of the vertebral column, right? This would be a lamina, and this would be the ligamentum flavum. It's coming basically straight up your spine. It's really cool because in Gross Lab, when you do a laminectomy, when you cut like the laminas out of the spinal cord in Gross Lab, you can actually cut along the whole entire spinal cord, and you can actually take the posterior side of the spinal cord completely straight off on one strip if you cut it perfectly down the laminas. And you can see the ligamentum flavum basically on the posterior side connecting all the laminas. So it's really cool. So
Justin?
Yeah.
I was just kind of wondering, like, how did you start studying for this class? Because, like, I'm thinking maybe, I guess, learn where everything is, but I don't really know where to go from there.
So yeah, so as we get more through the lecture, it's going to be more so like once you start learning all these materials or like learning where the structures are, you need to start asking yourself like second and third hand questions. So for example, once we start talking about like the brachial plexus and other nerve supplies, they'll be like, what happens when you sever the radial nerve, right? You not only do you have to know where the radial nerve innervates, like where does it go on the posterior side of the arm, you have to know what's going to happen when you sever it, like how many branches are going to be affected. Like you have to ask yourselves these third level questions because it's not just knowing like what supplies this and that's it. It's more so like he's going to ask you, okay, someone gets into a car accident, severs this nerve or loses this arterial supply, what's going to happen to this, and that, right? So the structures are the first thing you need to understand. But once you understand those things, you'll need to understand third level thinking as well. Does that help a little bit?
Justin,
yeah, a little.
So do we need to know these red arrows that don't have anything? So that would be like the IVD, the pedicle, and then the transverse process is what he's pointing at, correct?
Yeah. So, I mean, you'll know them because we talked about them throughout the slides, but he's not going to like post this picture and be like, what is this? You know what I mean?
Okay.
The only pictures I think he's going to post is going to be cadaveric pictures, so cadavers.
And that middle one is the pedicle, correct?
Yeah, that's the pedicle, yeah.
And then also, I see here he points to like these ligaments as well. Are those things that you want us to know? Because I didn't see them throughout the rest.
No. These are like the supraspinous. No, you don't need to know these ligaments. We'll talk about these when we get into like the pelvic lecture. We'll talk about more. Well, eventually you'll know these ligaments, but you don't need to know them right now.
Okay, thank you.
Gotcha. Okay, so here's another comprehension check. Wait, I went through everything, right? Yeah. So here's another comprehension check question. So which structure connects the vertebrae to the transverse process? So vertebrae to the transverse process. Yes, correct. That is D. D, the pedicle. So I inputted another picture here so you guys really understand what these structures are. So the interspinous ligament, remember, in between spinous processes, right? So again, you'll see over here, in between this spinous process and this spinous process is going to be the interspinous ligament, right? So in between spinous processes, lamina is going to connect the transverse process, the things that are poking out, to the spinous process, right? So lamina would be right here, connecting the spinous process. You can't see the transverse process, but it's poking out on the side, right? Ligamentum flavum, like we said, connects the lamina to the lamina, right? So ligamentum flavum right here, you see that? So I just inputted that picture because I feel like it really helped to show those structures. So again, like we said, this is the pedicle. Like we said, pedicle, vertebral body to the transverse process, lamina, transverse process to the spinous process, and then we talked about the superior and inferior articular facets, which connect to the adjacent vertebrae, right? Those are going to connect to like the top vertebrae as well as the bottom vertebrae, right? So he talked about the vertebral column. So, or he talked about the sacrum, I guess, for example. So we know that the sacrum is going to be a fused bone, right? So what's interesting to note about the sacrum is that the sacrum also has a superior articular facet, right? So, which meaning that it's going to connect to the lumbar vertebrae, because remember it goes cervical, thoracic, and then lumbar, and then sacrum, right? So the last lumbar vertebrae is going to connect to the superior articular facet of the sacrum, right? That makes sense. But you're not going to have a superior or inferior articular facet between S1, S2, and S3. You see that because these are like fused structures, right? Especially with the coccyx as well, which is also a fused structure. I think that's just the most important thing to note on this slide. So let me just go to this one. So he flew through this slide. I was shook. He flew through this slide, and I thought it was kind of confusing when he went through the paragraph, but I'll try to explain this. I kind of put this on like its own slide. So I copied and pasted this entire a little text thing, but I put it on the next slide so we can go through it like step by step. Yeah, so I'm just going to skip the slide, but don't worry, we're going to be talking about the same exact thing on this slide. I just feel like this does more justice. So like I added a couple images so we can really understand how these ribs are going to be connecting to the vertebrae, right? So this was his first point, right? So you have the superior costal facet. Okay, first of all, when you think of costal, think of ribs, right? So costal, anything that's going to be costal is going to be connecting to the ribs, or costal, whatever you want to pronounce it, right? Costal. The superior costal facet articulates with the inferior articular surface of the head of the rib of the same number. So what he means by that, so I just put a random image here, and this is just going to be random vertebrae that I named, but this is going to be the superior costal facet, right? So superior costal facet, inferior costal facet, transverse costal facet, right? So these are going to be things that when you think costal, you're like, okay, if it's costal or costal, it has to connect to the ribs, right? So these three things are going to connect to the ribs, right? These three things. Remember, this is superior costal facet. Over here, these are the articular facets. These are the ones that connect to the ribs. So we're not going to talk about it right now, but we're talking about costal facets. So the superior costal facet, this is just a random vertebrae, of the seventh vertebrae is going to connect to the inferior surface of the seventh rib. That's what he's basically saying here. He's saying the superior costal facet of, let's just say, vertebrae 7 is connecting to the inferior, when he means inferior articular surface of the head of the rib, he's just talking about the bottom portion of rib 7, right? So the bottom portion of rib 7 is connecting to the superior articular facet of vertebrae 7. Make sense? So, and then it's also going to connect, this is the next point, the inferior costal facet articulates with this, when he's talking about, it's just a fancy way, superior articular surface of the rib means the top part of the rib connects to the inferior costal facet of the 6th vertebrae, right? So it can get a little bit confusing, but we'll keep going through this so we understand this. And then you have the rib, which is going to be the tubercle of the rib, which is located right here, is going to connect to the transverse process of the same rib. So what I mean by that is that rib 7 connects to the transverse process of vertebrae 7, right? So here's some key points I wanted to say. Like, so costal, think ribs, right? Costal, think ribs. So with superior costal facet and the transverse costal facet are both going to connect to the same rib. Remember, the same rib. So the superior costal facet of vertebrae 7 connects to rib 7. The transverse costal facet of vertebrae 7 is going to also connect to rib 7, right? So it's okay. I feel like you can group these, the superior costal facet as well as the transverse costal facet, into the same category in regards to binding to the same rib, right? The inferior costal facet is going to be the different one. That's the odd one out. And that's going to be the one that's going to be from the vertebrae above, right? So this is going to be the 6th vertebrae inferior costal facet attaches to rib 7, right? Do you see what I'm saying here? So the superior costal facet and the transverse costal facet attach to the same rib. Same rib. So vertebrae 7, rib 7, and then this is going to be vertebrae 7, rib 7. But the inferior costal facet of vertebrae 6 is the one that attaches to rib 7. So I hope that helps a little bit. But I wanted to input this like slide or this image because it's easier to see that the tubercle right here attaches to here. It was very difficult for me to see that the tubercle here was going to attach right here. So I inputted this slide so you guys can see that the rib is going to curve out like this, which is how the tubercle attaches. So I thought this slide was really helpful when I made it. I'll be posting this as well. So
I have a quick question.
Yeah.
Sorry to cut you. So basically in the summary you said the superior costal facets and the transverse costal facets are basically the same thing and they connect to rib 7. So what's the difference between those two then?
Wait, say it again, sorry.
You said the superior costal facet and the transverse costal facet basically both connect to the same rib, which is rib 7. Then what's the difference between the superior and the transverse then?
Oh, the difference is based on location. So this is the superior costal facet. It's located basically on the vertebral body. The transverse costal facet is literally located on the transverse process. So it's located over here. So on the things that are sticking out, the transverse costal facet. The reason why they put costal is because it's connected to the ribs, right? So this little hole right here is on the transverse process. So they're like, okay, it's on the transverse process. It connects to the ribs. So this is called the transverse costal facet. Okay, you see what I'm saying?
I understand. Yeah, thank you.
Gotcha.
Okay. Justin, I had a question real quick.
Yeah.
So someone asked in the chat, for rib 1, would the inferior articular facet be connected to C7? Or would that be C7 for the inferior articular facet?
So for rib 1,
what are the two connections?
Okay, I see what you're saying. Yeah, so for rib 1, let me see. So I think rib 1 is going to be the one that's going to connect. Yeah, so I would assume it's going to connect to the thoracic vertebrae 1 on the superior costal facet, and then it's going to connect to the inferior costal facet of C7. Don't mark me on that. I'll double check that because I think it's a little bit different for rib 1 because rib 1 I think is a little bit smaller, so it might not connect to the top part of the inferior costal facet of C7, but I think for sure it's definitely going to connect to the superior costal facet of the thoracic vertebrae 1. So I'll definitely double check on that, but I doubt he's going to ask you a question on rib 1 because that's one that's a little bit ambiguous, just like how like rib 12 is a little bit ambiguous as well.
All right, cool. Thanks, man.
Gotcha.
I have a question. So do all 3 of these bones articulate at that same place there then together? The rib, like vertebrae 6 and vertebrae 7?
What do you mean?
They're all touching right there?
Yeah, right here, you mean?
Yeah.
Yeah. So they're all connecting right here. Yep. So they're connecting here, here, and here.
And it's the tubercle, which is articulating with the transverse costal facet. Okay,
yes.
Thank
you. This is the tubercle. Yep. And it connects to the transverse costal facet. Yes.
Oh, okay. Thank you.
Yep. Got you. Oh, when I say articulate, I mean like connect. If just to let you guys know. So articulating is the same thing as connecting. So for key points, so I just wrote a key point slide so you guys really understand. So the head of each rib articulates at 2 different vertebrae, right? Remember, this is the head of the rib. It articulates to this vertebrae as well as this vertebrae, right? That's what I mean by that. The tubercle of each rib articulates to the same vertebrae, right? So this is the tubercle, attaches to the same vertebrae. Remember, rib 7's tubercle is always attaching to the vertebrae of a vertebrae 7. You see what I'm saying? So that's going to be that. And I also wrote here, I kind of like bolt together the superior costal facet with the transverse costal facet articulating with the same rib, right? While the inferior costal facet articulates with the rib below. So for example, the inferior costal facet of vertebrae 6 binds to rib 7. Okay. Cool. So here's a comprehension check question. So which structure is the most anterior? The interspinous ligament, the supraspinous ligament, the posterior longitudinal ligament, or the spinous process? This is kind of a question based on something we talked about earlier.
I think it's A. I think it's A.
Let's see. Hold on. I'll wait until the chat goes.
Most interior. Not which is most. Anterior means what's in front of your body.
Yeah, anterior means what's in front of your body. I see a lot of mixed answers. I knew this is going to be a tricky one. Okay, so the answer is actually C, the posterior longitudinal ligament. So I made this a little tricky, obviously. So I put like which structure is the most anterior, and it's very difficult for somebody to put a structure that says posterior in its name as the most anterior, right? So I'll explain this on this slide right here. So we had the options. The posterior longitudinal ligament, remember, is located right here, right? It's actually going to be anterior, so in front of your interspinous process or interspinous ligament, which is between each spinous process, your supraspinous ligament, which is posterior to your spinous processes, as well as your spinous process, which is located right here. So everything I put into these answers, interspinous ligament, supraspinous ligament, and spinous process, are all behind the posterior longitudinal ligament. So technically, the posterior longitudinal ligament is the most anterior structure. I made that a trick question so you guys understand that just because it's called posterior longitudinal ligament doesn't mean it's the farthest one behind, right? So that's actually going to be the one that's most anterior. Obviously, if I put the anterior longitudinal ligament as one of the answers choices, this would be the correct one, right? Because this is going to be in front of that one. So I threw in a little trick question in there just to get you guys thinking.
Hey, is the posterior longitudinal ligament anterior or posterior to the neural arch?
Yeah, it's going to be anterior.
Thank you.
Mm-hmm.
Hey, Justin, when you post these slides, are the questions also going to be included on it?
I think I'm going to post them with the questions. At first, I didn't want to because I wanted people to come to the lectures, but I think I'm still going to post the questions because the questions I feel like are going to be really helpful, regardless.
Okay,
Hi.
thank you.
Yeah.
I had another question. So she just asked if it was anterior to the neural arch. So is it like inside of the body? I'm just having a hard time picturing where exactly it is.
Yeah, so there was a picture on this. Wait, let me see. I'll show you. Oh, right here. So this is the posterior longitudinal ligament, you see? This is going to be right behind the vertebral body, but they cut the neural arch, right? So this is actually going to be anterior to the neural arch. You see that neural arch is supposed to come wrapping around right here. So technically, the posterior longitudinal ligament is right on the wall of the vertebral body. Do you see what I'm saying? But on the posterior side.
Thanks.
Gotcha.
I have a question. So is the posterior longitudinal ligament anterior to the spinal cord?
Yes. Yeah,
Okay.
it is anterior to the spinal cord, yes.
Okay, gotcha.
Good question. Okay, let me get back to the next one. Okay, so for the vertebral column, we're going to talk about the cervical vertebrae. So the cervical vertebrae are just a little bit different. I note the differences here. So the biggest differences you need to know about the cervical vertebrae in comparison to the thoracic and the lumbar is that the cervical vertebrae is going to have a bifid process. Bifid meaning it's like a split process, right? You're not going to have that on any other vertebrae. They're all going to have like just like a pointed process. What I mean by that is that you're going to have this nuchal ligament. When he said this in the class, the nuchal ligament is going to attach to the bifid process. And you're thinking, oh, what is the nuchal ligament? So the nuchal ligament is actually going to be this structure right here. This entire structure right here is a nuchal ligament. So the nuchal ligament is going to be going down, down, down. Think of this as the bottom of your head, right? That's the bottom of your head. Attaching to that is going to be the nuchal ligament, but the nuchal ligament is going to turn into the supraspinous ligament. So as you can see, as you go down into the thoracic vertebrae, it's going to turn from the nuchal ligament, which is this entire web thing, into the spinous ligament, right? This is going to be the interspinous ligament. You can see the differences, right? So it's kind of like fusing or actually like getting smaller as it goes down towards the posterior side of your back, right? If you guys can see that. That's why you have a bifid process on the cervical vertebrae. So this webbing can attach to that, right? So it can attach right there. You're also going to have a really important foramen that you have to know. This is going to be the transverse foramen. The transverse foramen is going to have the vertebral artery. Remember, this is only going to be unique to the cervical vertebrae. The vertebral artery supplies the brain. Oh, it's obviously not going to be the main one because you have the carotid arteries, but the vertebral artery supplies the brain as well. And this is going to be going up the transverse foramen. You do not have a transverse foramen in any other vertebrae. Remember that. You only have a transverse foramen in the cervical vertebrae. Cervical vertebrae are going to have a transverse foramen so that you can have this vertebral artery coming right up, which is located right here, right? Vertebral artery coming right up. And then remember, like I said, we're talking about a lot of foramens. So you want to know the differences between each, right? Transverse foramen, remember, is vertebral artery. Vertebral foramen contains the spinal cord, right? So we have to keep that in mind that we know the differences between these foramens. So a little summary right
Justin,
here I put. Yes.
Can you just repeat the nuchal ligament turns into what ligament?
It turns into the supraspinous ligament. So this is going to be the supraspinous ligament right here as it goes down. Because remember, in between each spinous process is going to be an interspinous ligament, right? As we go down, right? But this entire webbing is actually called a nuchal ligament. But think of the nuchal ligament as like, this is just going to be a webbing that's going to eventually turn into the supraspinous ligament. And you're also going to have the interspinous ligaments in between each spinous process. Does that make sense?
Yeah, thank you.
Okay, gotcha. So here's a section summary that I posted for you guys. So vertebral artery passes through the transverse foramen. Remember, but the spinal cord is going to pass through the vertebral foramen, right? This is vertebral foramen. This is the transverse foramen. Okay, so about the cervical vertebrae. So for cervical vertebrae, you're going to have the atlas and you're going to have the axis, right? So the atlas, the way I like to remember is like the atlas holds the world up, right? So that's going to be your C1. It holds your head up, right? So this is going to be the atlas. The atlas will be located right here. This is going to be C1. So it's going to have, you see, it's also going to have the transverse foramens, right? These are transverse foramens. Vertebral artery is what is supposed to be coming through here. And this is going to be the vertebral foramen, which contains the spinal cord, right? C1 actually doesn't have a vertebral body. So like there's no vertebral body here, right? Like he said in class, embryologically, the vertebral body of C1 actually turned into the dens, which is actually connecting to C2, right? So when you think of dens is going to be connecting to C2. Or no, dens is a part of C2, correct me. So dens is a part of C2. So this is technically like the vertebral body of C2, and this is going to be the axis. So again, you have atlas, which holds your world up. That's going to be C1, and your axis, which will be right below that, that'll be C2. That's going to be allowing you to like, we'll go through on the next slide, but allows you to go no, or make the no like go like this with your head. So yeah, we'll go through this on this slide. So the best way I like to remember these two joints, because I mean they're pretty long names and they can kind of sound the same, but atlantoaxial joint, remember, is going to be between the atlas and the axis, right? So that's going to be between C1 and C2. So the best way I like to remember this is like AA, like I just said like earlier in the lecture, it's like AAA, like when you talk to somebody, AA, it's like a no thing. So it's allowing you to pivot. So your dens is going to be connecting right here to C1, right? To your atlas, right? And this dens, think about it like sliding left and right, basically. It allows you basically to do that like no action, right? So remember, atlantoaxial AA, so it allows you to go no, right? So your atlanto-occipital joint is going to be between your C1 and your occipital condyle, which is just a portion in your brain, right? It's going to be located right here. That's going to allow you to go yes. So atlanto-occipital, I think of AO, like when you say hi to somebody, I don't know, people probably don't do this, but like AO, like that, like it's kind of like, okay, you get to do that yes. So that allows you to go up and down. So AO. I feel like that's a little quick mnemonic that can really help you guys to remember the differences between those, because they're pretty long names and they can kind of sound similar. But if you remember AA for no and AO for yes, that's going to allow you to know the difference between what these movements and what these joints actually do. Okay, so he basically just like brushed upon this slide really quickly, but I guess this would just be the anterior longitudinal ligament. Like we said, we talked about this before, and this would be the transverse foramen in the cervical vertebrae, which is allowing the vertebral artery to go up. Not too much on this slide. So you're going to have the atlantoaxial joint. Remember, that's your AA joint. So your AA, like your no joint, right? So it allows you to go no. Remember, like we said, you're going to have, actually, your tectorial membrane is actually going to turn into your posterior longitudinal ligament. Remember, we talked about the posterior longitudinal ligament being just behind the vertebral body, right? So this is the vertebral body, and this is going to be the posterior longitudinal ligament. Your posterior longitudinal ligament actually comes from your tectorial membrane, this is your occipital bone, your occipital condyle over here. This is all the way up in the top, like in the bottom of your head, basically. It's actually called the tectorial membrane. That's what they call it. But as you move down throughout the cervical vertebrae, it's just going to be called the posterior longitudinal ligament. So that's why over here, the tectorial membrane turns into the posterior longitudinal ligament, right? So another thing he actually talked about on this slide was that you're also going to have the cruciate and the alar ligaments, right? So cruciate and alar. This is really important because, so for example, you have the dens. Remember, the dens comes from C2, right? Comes from C2. You're going to have these ligaments behind the dens that are going to be protecting it. So it's called the cruciate ligament because this looks like a cross, right? So this is going to be a cross. This would be the cruciate ligament. These would be the alar ligaments. Remember, picture this to be the dens. These ligaments are going to be behind the dens. So what is the reason for that? Like you're probably thinking like, oh, what's the purpose of these ligaments? The purpose of this is, for example, if your dens breaks off, if it goes posterior and you don't have those ligaments, your dens is going to sever your spinal cord, and obviously you can be paralyzed. It can lead to multiple issues, right? So this is why you have these ligaments back here, these tough ligaments, the alar ligaments and the cruciate ligaments, to protect the dens from not breaking posterior and puncturing your spine, right? So that's why you have these ligaments right here, right? So those are really important as well.
Justin?
Yes.
I just because I can't tell from the picture, are the alar ligaments and cruciate ligaments on either side, proximal and distal to the dens, or are they both on one side of it?
Yeah, I know the picture makes it a little hard to see, but think of it as like, okay, so this is the furthest back part, right? This is why they make it in like dark, I guess, or like dotted lines. The dens is in front of this. So if you were looking on the back side of your body, you would first see the cruciate ligament, then you would see the dens. and then the alar ligaments actually connect like obliquely or to the corners, like diagonally of the dens. So it kind of holds the dens in place like diagonally like this.
Oh, okay, so it's not anterior to the dens. It's
no.
Okay.
Yeah, it's kind of like holding it like on the corners of it.
Okay.
Yeah. Does that make a little bit more sense?
Yeah, thank you.
Okay.
And those are important for protecting the spinal cord from the dens, right?
Yes. Yes. Okay, so
essentially the dens is sandwiched between the cruciate and the alar ligaments.
So I wouldn't say sandwiched because like the cruciate ligament is posterior. Yeah, the cruciate ligament is posterior to the dens, but the alar ligaments, think of it as like you kind of have this dens holding up, and the alar ligaments are connecting to the corners of it. You see what I'm saying? So it's kind of like holding it up like strings, basically.
Okay, thanks.
Do you see what I'm saying? Yeah.
Does the spinal cord run on here run posteriorly to the cruciate ligament?
Yeah. Yes.
Okay.
Yes. Okay, so
spinal cord is anterior to the tectorial membrane.
You said is the spinal cord anterior?
Yeah, to the tectorial membrane.
No. No, because the tectorial membrane turns into the posterior longitudinal ligament, and remember the posterior longitudinal ligament. Think about it as like this is literally attaching to the backside of the vertebral body. So what's posterior to that is going to be the spinal cord, right? So the spinal cord is technically behind this. Does that make sense?
Yeah, that makes sense. Thank you.
Okay, gotcha. Okay, so here's another comprehension check question. So we're talking about the ribs. I wanted to get back into the ribs again so you guys don't forget it. So the 8th rib articulates with all of these structures except which one? So, I mean, this is superior costal facet, inferior costal facet, transverse costal facet. All right. So yes, a lot of people in the chat did say D, none of the above. That's really good. Yeah, it's hard to pick an answer none of the above because you're like, oh gosh, it's got to be one of these. But no, it is actually none of the above. So I inputted the picture right here just so we can really understand it again. So the 8th rib, remember, you can kind of group the superior costal facet and the transverse costal facet in the same category in regards to binding to the same vertebrae, right? Or binding to the same rib. So again, like we said, so you have the 8th rib. So when I see 8th rib, I'm like, okay, 8th rib. So I know superior costal facet and transverse costal facet, that's the same one. Those both got to be 8, right? So the superior costal facet is the 8th one. The transverse costal facet is the 8th one. And like we said, now we have to see, okay, is the inferior costal facet the 7th or the 9th? Remember, the inferior costal facet articulates to the rib below. So the inferior articular facet of vertebrae 7 articulates to the rib below, which is rib 8, right? While the superior costal facet and the transverse costal facet articulate to the same rib. Does that make sense? So I put the picture here again so we can remember like which things are going to be articulating with what. And good job on those, y'all. None of the above was the correct answer. So we're going to go through the back. So we'll go through the back little by little. So we'll talk about the innervation arterial supply, and we'll talk about some cadaveric images as well. So
I asked about the last question.
What happened?
So, is none of the above again?
Can you repeat the question? Sorry, I didn't hear you. Did you repeat it? I didn't hear.
Yeah. Oh, why is the question none of the above?
Why is the question none of the above?
Mm-hmm.
So like I said, so the superior costal facet and the transverse costal facet can be associated with the same category when in regards to rib, like articulating with ribs. So the superior costal facet of the vertebrae 8 and the transverse costal facet of vertebrae 8 both bind to rib 8. So what I mean by that is they all bind to the same rib. So this has to be right, and this has to be right as well. So now the inferior costal facet, like we said, articulates with the rib below. So the inferior costal facet of vertebrae 7 articulates with the rib below that, which is going to be rib 8. So this is the correct answer as well. So then that means it's going to be none of the above. All of these are correct.
Oh, okay. I read the question wrong. Thank you.
No, you're good. You're good. Okay, so we'll go through the back. So, I mean, he just skimmed through this, but you have connective tissue surrounding your muscles, tendons or aponeuroses. Aponeuroses are more so used for flat muscles like the external obliques, the internal obliques, muscles that are associated with your abdomen. Tendons are more so associated with like your biceps and other tendons as well, or other muscles as well. You have proximal and distal. He didn't, I guess, care too much about using like, oh, insertion is proximal and origin is distal. Just know that they're like almost interchangeable at that point. But yeah, that'll be it for that slide. So for isometric and isotonic, so isometric, remember, is going to be does not shorten and like no movement occurs. So for example, when you're holding a plank, that's going to be an isometric exercise, right? Because the muscles aren't shortening and they're not elongating either, but you're still exercising, right? That's going to be an isometric. Isotonic is going to be, for example, like we said, a biceps curl. So anything that's going to be isotonic is going to be for example, like a biceps curl. Remember the mnemonic? So a mnemonic that my TA actually used last year that helped me was like Vakatonic, like makes you move. So Vakatonic helps you move. It's going to help you remember that isotonic is the one that moves, like that shortens or elongates your muscle, right? Isometric is going to be the one that keeps it the same, right? I mean, I didn't want to write it on the slide because I don't know what if Muffley sees that, but Vakatonic, like we said, is going to help you move. So that's an easy way to remember that isotonic is going to be the one that's going to deal with movement and changing the movement, while isometric is the one that keeps you in the same place, right? Okay, so he just expanded upon it here. I don't think this is too important. We can skip this.
Real quick, Justin.
Yeah.
So for isotonic movement, is that only a concentric movement because the eccentric is elongating and he said shortens specifically?
Yeah, so I know somebody asked a question about that in lecture, and like he was a little confused, I think, about it, but I think isotonic, I looked it up, and isotonic does have categories of concentric and eccentric, but it can be shortening, I think, and elongating as well. But he's not going to ask you if concentric or eccentric is isotonic. He just wants you to know that the muscle length is changing, and the other one it's not. So you don't have to hone in too much onto that, I think.
Okay, thank you.
Gotcha. Okay, yeah, we skipped this slide. So muscles can only push as they contract. Muscles cannot pull. So remember, like we said, each time you're making a movement, like when you're bicep curling, your biceps is pulling on another bone, right? So it's pulling on a bone. Like we said, you're never pushing. Your muscles are never pushing in any direction. So, and you also have muscles that are going to be opposite to each other, also known as antagonists. The biceps brachii, which is like a flexor, is going to be antagonist to the triceps brachii, right? Which is just be opposite, right? So we have prime movers, we have antagonists, and we have synergists, and we also have fixators. So prime movers, like we said, that's the one that deals with majority of the movement, right? So I gave an example of biceps brachii. If you want to flex your arm, use your biceps brachii, right? Antagonist is going to be the one that does the opposite, right? So your triceps are going to do the complete opposite of your biceps brachii, right? Synergists are going to be ones that help with the movement, but they're kind of like not like the main movement. So for example, when you bicep curl, your biceps brachii is like the prime mover, right? But your synergists help move it. So this is why I put this image right here, because we haven't talked about these muscles yet, but I wanted to show you. You have like the coracobrachialis, which is going to be located right here, and you have the brachialis, which is located right here, right? These are also on your anterior part of your arm, so they also help with flexing, but they're not like your prime movers, right? It's not the biceps brachii, but they also do help with flexing, so that's why they're called synergists, right? So they're going to help the prime movers do their movement. So that's why I put coracobrachialis as well as the brachialis. Fixators are just going to be things that like stabilize one bone in order to flex the other. So for example, if you stabilize the shoulder, it would be much easier to flex your elbows, so you can like isolate your biceps brachii, right? So this is going to be skeletal muscle, prime move. Okay, so for this slide, he just like flew through these stuff, but I did write same Dave in order to help us. We don't need to know the Dave part right now, but later on we will. Same Dave is an acronym that means sensory is going to be afferent, right? So S for A. So sensory means anything that's going to be touching your skin, right? So or anything that goes from like the surface to your spinal cord, right? So if something like touches you and then you notice that you felt it, that's going to be a signal that's sent from the surface of your skin to your spinal cord. That's going to be afferent. So sensory is called afferent. M, which stands for motor is going to be efferent. Motor is going from the spinal cord to the surface of the skin. So if you tell your, or you don't tell your muscle, but if you want to flex your muscle, like so if you want to flex your biceps, that's going to be a motor movement, right? Because your spinal cord is sending a signal to your biceps to like flex, right? That's just for you to remember like the difference between motor is efferent and sensory is afferent, because I know that can get a little confusing. Dave, we'll talk about that later, but that's just talking about like the dorsal root ganglia and then the as well as the ventral, but we'll talk about that later. That's not too important right now. Okay, and then this is another prime mover. This is just for extension. So you have antagonist muscles, like we said. This is going to be, for example, the biceps brachii. This would be the triceps, flexor, extensor, etc. But remember, note that the antagonist is going to help you do smooth movements. They're not just going to obviously just only oppose like your movements. Like if you didn't have your extensors, If you try to flex your arm will just go all over the place. Your extensors help you have a controlled movement, like we said. So they're there for an important reason, not only to antagonize, but also to allow for smooth movements. Okay, so here's another comprehension check. So we're going all the way back to the beginning so that I like to recap on earlier stuff so that we're still like keeping the material fresh in our minds. So which area does the vertebral artery pass through? Is it A, B, C, or D? All right, nice. Yes. So the answer is B. B. I wanted to make this like a two-part question, so you guys understand that the transverse foramen is only located in the cervical vertebrae. Remember, the transverse foramen is only located in the cervical vertebrae, so you can completely wipe out A. There's no such thing as a transverse foramen in the thoracic vertebrae. There's only transverse foramen in the cervical vertebrae. And if you know that the vertebral artery passes through that, then you know that the answer choice is B. For vertebral foramen, remember, the spinal cord is going to go through the vertebral foramen. And you have a vertebral foramen in all your vertebrae, right? So, for example, in the thoracic vertebrae, it'll still be the spinal cord. And then your cervical vertebrae will still be a spinal cord as well. So that's the differences between those. But good job. So yeah, that's why I posted this picture again. So remember, transverse foramen right here, vertebral artery passes through. This is the cervical vertebrae. And you also have a vertebral foramen, which is right here, which all of the vertebrae have. This is going to be where the spinal cord goes through, right? That's why I added that slide. Okay, so we're going to have back muscles. So we're going to talk about the back muscles. We're going to talk about innervation. We'll talk about arterial supply. We'll talk about attachments. So we'll get right into this. So yeah, so the ventral primary rami is going to, this is just a note, we'll get into this more later, is going to innervate the superficial back muscles, while the dorsal primary rami is going to innervate the deep back muscles. What I mean by that is like the dorsal, like I said, like the way I like to remember this is D for D. So dorsal primary rami for deep back muscles. Dorsal primary rami for deep back muscles. So that's the way you can associate dorsal with that. Ventral primary rami become like so many other things in the rest of your body, like the brachial plexus, your cervical plexus, your sacral plexus, like all these other things. But your dorsal one is going to be innervating the deep back muscles. Okay, so this is going to be broken up into a couple categories. So we have this. These are all considered superficial back muscles. All of these. These are just categories in the superficial back muscles. So you have the most superficial one is going to be the trapezius and latissimus dorsi. Then you have the intermediate, and then you have the deep. And these are going to be the true back muscles or the deep ones. He didn't place too much emphasis on these. So once we get into the deep back muscles, we'll like kind of like fly by through it because I'll only talk about the high yield stuff that he talked about because those are going to be the most important ones that he'll test on. So, so for the trapezius, like we said, here are going to be the proximal attachments and distal attachments, right? So when I talk about proximal, I mean anything that's closer to the midline, right? So if you think about these, like they kind of make sense, right? The names make sense. So I'm thinking about the trapezius. If you know that it's like a trapezoid muscle, right? It's going to be this muscle right here outlined, right? This muscle. If you think, okay, proximal attachment, I have to think midline, like something that's across the midline. So you're like, okay, so these proximal attachments would be occipital bone. Okay, yeah, that makes sense. It's on the midline. The nuchal ligament, which is right here, I posted it right here. The nuchal ligament, remember, turns into the supraspinous ligament right here. So the nuchal ligament, which would be up here, makes sense. That makes sense. So trapezius should be attaching to that, right? The supraspinous ligament, okay, that makes sense again because remember, the nuchal ligament is going to turn into the supraspinous ligament as it goes down the vertebral column, right? And then you have the spinous processes of C through T. So the cervical vertebrae up here, all the way down to the thoracic vertebrae because we know the trapezius is a very large muscle. So it extends all the way from the cervical vertebrae to the thoracic vertebrae. So if we just think about the muscle in and of itself and where it's located, we should be able to understand where the proximal attachments are. For the distal attachments, that means anything that's going to be attached like further away from the midline, right? So it'll be attached to the spine of the scapula, which is located right here. This is the spine, the lateral clavicle, as well as the acromion process, right? So this is going to be the same thing over here, right? That's going to be distal attachment. So we'll keep going through these, and I'll keep reiterating these throughout the PowerPoint so you really understand where the attachments are for the trapezius. So again, like I said, this is the trapezius attaching distally to the lateral clavicle, which is right here, the lateral clavicle, as well as the acromion process and the spine of the scapula, which is posterior. So for arterial supply, so for the trapezius, it's important for us to note that the subclavian artery is going to turn into the axillary artery. The axillary artery is going to turn into the brachial artery. So what I mean by that is, okay, so for example, you have your heart, right? Your heart is going to branch off into your aorta, like we said, which is going to be like the largest artery that comes out of your heart. And that's then going to branch off into your subclavian artery. Your subclavian artery, think about it, is coming almost towards your clavicles, right? So your subclavian artery is going to turn into your axillary artery. Axillary, think of like the axillary region, like your armpit region, right? So your axillary artery comes right around there. Your axillary artery just turns straight into your brachial arteries, which is the artery that goes straight down your arm, right? So as it's shown right here, this would be the subclavian artery, this would be the axillary artery, and this would be the brachial artery, right? So they're all the same artery, they're just named differently as they go down the segments, right? So if you think about what he says, he's like, okay, so the dorsal scapular artery and the transverse cervical artery are going to supply the trapezius, right? So these two arterial supplies are going to supply the trapezius. Remember, these are both coming from the subclavian artery, right? Because it's very high up right here. This is the subclavian artery. This would be the transverse cervical, and this would be the dorsal scapular. It's really important to note that these two are going to supply the trapezius, because as we go on throughout the muscles, we'll talk about more arterial supplies and innervation, but it's really important to know that the dorsal scapular and then the transverse cervical artery are going to supply the trapezius muscle. Don't worry, we'll keep reiterating this. I'll keep asking questions so we really understand what's going to be our arterial supply. So for
Hey, Justin, I have a quick question, actually.
Yeah, of course. Shoot it.
When it comes to attachments, for example, with like spinous processes, if you're going to expect us to know, specific like numbers, like cervical 5, or do we just need to know like cervical and thoracic spinous processes?
Yeah, you just need to know cervical thoracic. Yeah, so if you think about the trapezius, it goes really high up on the back. So you're like, okay, so it has to have some cervical vertebrae. And you know that the trapezius goes really low. So you're like, okay, it has to have some thoracic. So if you just think about it generally like that, that's all you need to know.
All right, thanks, man. Gotcha.
Okay, so I'll keep reiterating these things so you guys really remember the topics. So we have trapezius. So this is going to be the innervation. So when I mean innervation, I mean the nerve supply, right? So those can be used interchangeably. So innervation, like we said, of the trapezius, you're going to have the accessory nerve. This is super, super, super important to know this. Like this is like really important. This is going to be this is actually the only muscle that we're going to talk about in this lecture that's going to be innervated by a cervical plexus nerve. So this is going to be cranial nerve 11. It's important for us to remember that the spinal accessory nerve is the same thing as the cranial nerve 11, right? So he can put on an exam, okay, like this is like the trapezius, what's going to be the innervation? And he puts a bunch of Roman numerals. If you don't know the Roman numerals, you don't want to get the question wrong because I know it's spinal accessory, but I don't know I didn't know it was cranial nerve 11, right? So you want to know that these are going to be the same thing. Cranial nerve 11 as well as accessory nerve are the same thing. Well, spinal accessory, same thing. So those are going to be cranial nerve 11. This is super high yield. Super important to know this. Yes. Okay. So that's that. So this is going to be a cadaveric image. So you can see this is the trapezius, right? So I'm like, okay, trapezius, pretty large muscle. I'm thinking proximal attachments, right? So anything that's towards the midline. I'm like proximal attachments. Remember, like we talked about, okay, so it's going from like the cervical vertebrae. This is where like I would think about it. Okay, it's going from the cervical vertebrae to the thoracic. Okay, that's an attachment. Good. Okay, it looks like it's attaching to the nuchal ligament because it's pretty high up. Okay, makes sense. Nuchal ligament turns into the supraspinous ligament down here. So it has to attach to the supraspinous ligament. And then these are all spinous processes, right? So it also has to attach to the spinous processes. So if you just think about where the trapezius is and you start like locating where exactly these structures are, you'll be able to understand what the proximal attachments are. Distal, it's going to be a little harder to remember, but if you remember, like I talked about before, it would be the spine of the scapula right here. You have the lateral clavicle, which is anterior, and you have the acromion process, which is over here. So this is actually the spinal accessory nerve. So it's definitely fair game if he puts this on the exam and he's like, oh, okay, what's going to be? He covers this right here and he's like, what nerve is that? Well, he might not even say what nerve is that. He might just say, what structure is this? And you have to know what that is. That's going to be the spinal accessory nerve. So he said he might cover this up and just post this picture on the exam and be like, okay, what is that? And you have to know, first of all, you have to know that's not an artery. And then second of all, you have to know that this is going to be the spinal accessory nerve. This is what nerves look like in cadaveric images. They look a little different than arterial supplies. So yeah, so this is definitely fair game. So I would definitely look into these cadaver pictures as well. Okay, so here comes another comprehension check. So this is going back again. So which joint allows a person to shake their head in a no motion?
I had a question. When on the previous, the one with the cervical plexus slide, when you had BRS period, that means branch, right?
Yep, that means branches. Yep.
Okay, thanks.
Okay. Yes. So yes, you guys are correct. 43 responses. Okay. So yes, the answer is B. So it's going to be the atlantoaxial joint. Remember, AA, like AA, like that's your no joint, right? Your AO is going to be AO, like that's going to be your yes joint, right? So this is going to be between C1 and C2, and this is going to be through occipital condyle and C1. I just put A and B and none of the above, just as extra answer choices. So for the trapezius, I kind of put like a mnemonic in order to remember like the trapezius and its movements. I put dear trapezius, like you're writing a story or whatever. Dear trapezius, blah, 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 blah. So that's going to be helping you remember that the trapezius helps you depress the scapula, which means brings it down. It helps you elevate the scapula, which means brings it up. It's going to help you adduct, so adduct, so which means the same thing as retracting, which means pulling your scapula back, right? So when you're adducting your scapula, it means you're just pulling it back, right? And it allows you to rotate your scapula forward, right? So basically bring your scapula like kind of like forward like that. That's going to be your trapezius. So the best way to remember that is dear trapezius. But remember, it's going to be AD, so adduction. But yes, dear trapezius.
Hey, Justin, I have a quick question with the cadaver picture that was posted.
Yes.
Yeah. With the cadaver, yeah, this one.
Mm-hmm.
With those photos, is there you were saying that there's a section on Canvas where those cadavers are posted?
So all the cadaver pictures that he'll use for the exam are going to be based out of the PowerPoint. So you don't need to worry about going to Ackland and having to find these images. The only ones that he's going to use that are fair game that he said is going to be coming out of the slides. So as long as you study the slides, an image shouldn't surprise you. It might surprise you because it's blank and it doesn't have anything labeled on it, but it's going to be most of the images that are going to be coming from the slides.
Oh, okay, so mostly on the exam, he'll use like one of the pictures from his PowerPoints, but he'll like maybe like block off like the.
Oh yeah, yeah.
Okay, thank you.
He'll for sure block out. Yeah.
All right, thank you.
Gotcha.
Justin.
Yeah.
On that last slide with the cadaver, are there any good tips for trying to remember what nerves will look like versus blood vessels on cadavers like this?
Yeah.
This thing to look for other than just memorizing this specific photo.
Yeah. So so for nerve supplies, so for example, this is a nerve, and then these are nerves as well. So if you realize this is actually going to be part of the brachial plexus. So if you think about where this image is, you're like, okay, so he's pointing at the trapezius, right? This is going to be the brachial plexus because this is going down your arm. We'll talk about that later, but you don't need to worry about it right now. And this is going to be the spinal accessory nerve because you're like, okay, so this is going to be above the brachial plexus. What's above the brachial plexus? The cervical plexus. And you remember, okay, the only muscles that's innervated by a cervical plexus is going to be the trapezius. So this has to be the spinal accessory nerve. So you see what I'm saying? And you remember for the trapezius, the trapezius actually has two arterial supplies, the dorsal scapular as well as the transverse cervical artery, right? So this is going to be, as you look at more images, you'll notice that, okay, this is a nerve because it's more clear. These nerves look more like clear in cadaveric images. So that's kind of like the thinking that I would give when I start looking into these images. Does that help a little bit?
Yeah, thank you.
Okay, gotcha. Okay, where are we at? Okay. Yeah, so we were here. So again, like I said, I'm reiterating this just so you guys really, really just understand. He went on the trapezius a lot, so I definitely think this is going to be a testable question. So again, like he said, he could put this image and be like, what's the arterial supply of this muscle? He's going to cover trapezius and be like, what's the arterial supply of this? So you have to be like, okay, that's the trapezius, and what's the arterial supply? Then you have to remember, like we said, it's going to be dorsal scapular and transverse cervical, right? So here are the proximal attachments located in red, right? This is going to be the spinous processes, as well as the supraspinous ligament and the nuchal ligament, right? All down here. Occipital bone up here, right? That's going to be for the trapezius. The distal attachments are in blue, right? You see in blue, spine of the scapula, which you can't see too well here, but the spine of the scapula, acromion process, and the lateral clavicle, right? It's the same thing over here. It's going to be that. So, which cranial nerve innervates the trapezius muscle?
You ramped it up for this one.
I'm trying to get you guys prepared. Muffley doesn't ask easy questions, so I want to make sure you guys are ready. Okay. So yes, it is C. So C, like we said, the last thing you want to do is get a question wrong in the exam because you don't know the differences between a Roman numeral. So again, like we said, it's going to be spinal accessory nerve, and this is going to be cranial nerve 11. This is just going to be, this is the number 9, this is 10, and then this is 5, right? We'll talk about, you'll learn all the cranial nerves as we get later on into this course, but remember, the only one you need to know right now is cranial nerve 11, trapezius. Okay, so here's a little summary slide I wrote for you guys. Just a picture perfect image of like what you need to know, like that's really high yield for the trapezius. So again, innervation, spinal accessory nerve, cranial nerve 11, arterial supply, dorsal scapular, and transverse cervical, right? It's going to be 2 arterial supplies for the trapezius, and again, D or trapezius, right? So it's going to be depress, elevate, adduct, so adduct, and rotate the scapula upward, right? So that's just a little summary slide. Don't worry, I'll post it when I post the slides later on, just to help you guys out a little bit. So we'll have latissimus dorsi. This is the next one we'll talk about. So this is 100% high yield, like definitely testable, 100% right here. I put a huge star, medial lip of the bicipital groove. Like that's going to be extremely important because as we go on like throughout the course, and we talk about more lectures, there's going to be a lot of things that attach to the bicipital groove. You're going to have stuff attaching to the lateral lip of the bicipital groove. You'll have stuff that attaches to the floor of the bicipital groove. And what is the bicipital groove? It's also called the intertubercular groove, right? What that is basically just a little groove on your humerus, right? So on your humerus bone. I posted a picture on it, like in the next slide, a few slides coming up. It's just a little groove on your humerus that a lot of muscles attach to, right? So yes, your latissimus dorsi goes all the way to your arm. Yeah, so it actually connects to the medial lip of the bicipital groove of your humerus. So that's why it allows you to do like that wader's tip motion, which we'll talk about later. So that's going to be that for that one. And then we have proximal attachments, like we said. If we think about the latissimus dorsi, we're like, okay, latissimus dorsi, it's a little bit lower than the trapezius. It is, right? Because the trapezius is up here, latissimus dorsi is lower. So I'm like, okay, it has to be the spinous processes T through L. We talked about the trapezius. We're like, oh, that's got to be C through T, right? Cervical to thoracic. But we're like, okay, the latissimus dorsi is pretty low. So I know it's going to have some thoracic vertebrae, but it's also going to have lumbar because, look, the latissimus dorsi goes all the way down to the crest of the ilium. That's really low, right? So crest of the ilium as well as the sacrum. So it's important to note like where these muscles are. But high yield, 100% medial lip of the bicipital groove for the trapezius. So yeah, I inputted an image right here. So this is what the bicipital groove is right here. So the latissimus dorsi would technically be attaching right here to the medial lip of the bicipital groove. That's what they mean, this part, medial lip. This is the groove. This is the medial lip. Because this is going to be, for example, the humerus that's attaching to your right arm, because that's the way it's shaped. That would be the one on the right arm. This would be the medial lip of your bicipital groove. That's where the latissimus dorsi attaches to, right? So you see right here, here's the medial lip. This would be the lateral lip, right? Medial lip, lateral lip, and this would be like the floor, right? So again, like we said, latissimus dorsi, medial lip of the bicipital groove. So I call it latissimus dorsi and a few other muscles that we are going to talk about, like happy muscles or like muscles of the same sign. Because what's good about these muscles is that they have the same name of their arterial supply as well as their innervation. So what I mean by that is that the arterial supply of the latissimus dorsi is thoracodorsal artery, and the nerve supply of the latissimus dorsi is thoracodorsal nerve. So that helps, right? So you're like, okay, latissimus dorsi, it's going to be the same thing. I mean, obviously this is a nerve and this is an artery, because this comes from the brachial plexus and this comes from the axillary artery, but they're named the same way. So that's what helps a lot with that. So when you think of latissimus dorsi, think of a happy muscle. That's a happy muscle. When I think happy muscles, I think of muscles that have the same innervation name as well as their arterial supply. So that's going to be that. Okay, yes, I'll talk about that. Okay, so, and then, yes. So that's going to be happy muscles. I'll call them happy muscles. So here is the latissimus dorsi. You talked about wader's tip. So wader's tip, I posted this picture on the lecture when we were in it. So you have extension, adduction, and medial rotation. So that's exactly what this guy in the image is doing, right? So extension meaning you're pulling your shoulder back, right? You're pulling your shoulder back. Adduction or adduction means you're keeping your shoulder close to your body and you're immediately rotating your arm, basically like turning it inwards, right? So again, if you do that exact movement, you should be able to feel your latissimus dorsi basically like contracting, right? So that's going to be wader's tip. They call it wader's tip because it's like the waiter like walking away, asking for a tip, like we said, because he's sitting him like in a good spot in the restaurant, right? That's why it's called wader's tip. So he talked about Erb's palsy for a little bit. Yes.
How is that medial rotation?
So when you think about it, so I'll start with the first movement, extension. Extension is bringing your shoulder back, right? So you're bringing your shoulder back. That makes sense, right? Adduction or adduction is going to be making sure your shoulder stays close to your body, right? Close to your body. Abduction will be keeping it away. So you want to keep it close to your body. Medial rotation is going to be, for example, like we said, turning your hand this way is medial rotation, while turning your arm this way is lateral rotation. I don't know if you see, but like that. So medial rotation will be turning this way. Like I said, turning your shoulder this way, that's medial rotation. Lateral rotation will be turning outwards, if that makes sense. Do you see what I'm saying?
I think so. I think I just need to like look at a picture of how it looks.
Okay.
Maybe.
So it's like, so if you put your right arm backwards, like we said, and you turn your right arm, if you have your arm backwards and you turn your hand inwards, basically inwards while it's backwards, that's medial rotation. If you turn your hand outwards, that's going to be lateral rotation, basically, if that makes sense. It'll help more if you look into an image on that, but I hope that helped a little bit.
It did. Thank you.
Gotcha. Okay, so he talked a little bit about Erb's palsy. So he didn't expand on this too much, but for the brachial plexus, he kind of just threw that in there, but I threw a picture of the brachial plexus. This is just a very skeleton image of the brachial plexus, meaning that there's obviously way more branches that come off the brachial plexus, but this is just very, very basic branches off the brachial plexus. So what he means, okay, someone that has Erb's palsy, you have damage to C5 and C6. The reason why I inputted this image is so that you can understand what he's talking about. C5 and C6 actually come together. These are spinal nerves, right? Coming from these are coming from the spinal cord, right? Or spinal roots, right? So they're going to come together and they're going to make this, or the superior trunk, and then they're going to branch off, right? So think about it. If you damage anything from C5 and C6, anything down the line is basically damaged, right? So you never want to obviously damage a root. If you damage a root, like we said, that's going to be like huge, huge consequences, right? You'd rather damage like a branch, which has only like a specific, we said innervation, rather than roots, which have contributions to almost everything, right? So that's what they said. If you have if you have damage to C5 and C6, it's going to affect all these muscles, right? The deltoid muscle, which is innervated by the axillary nerve, because axillary nerve comes off eventually a branch of C5 and C6. For example, the biceps brachii, the coracobrachialis, these are all innervated by the musculocutaneous. You don't need to know this right now. This is just for you to understand like what he's talking about. The biceps brachii and the coracobrachialis are all innervated by the musculocutaneous. Musculocutaneous comes from C5 and C6. So if you're damaging C5 and C6, your biceps brachii and your coracobrachialis are not going to be able to function, right? So that's what he's talking about of how serious it is if you damage these certain roots. So I just wanted to throw that image in there so you guys really understand what he was talking about when he was talking about Erb's palsy. I hope that makes a little bit more sense. Okay, so this is an image of the latissimus dorsi. Yes.
I have a question about the Erb's palsy.
Yeah.
So what he said after he like described that whole thing was that like Erb's palsy, like damage to these nerves affects the muscles that abduct, flex, and the lateral rotators. So what you have instead is the extension adduction and the medial rotation.
Yep.
So what he was he meaning that like someone with Erb's palsies, their arm is like kind of in the waiter's tip, like
yeah,
like,
I guess, yeah. I think that's a thing that you can assume. Yeah, since if you are damaging those, you'll have adduction, you also have extensors, and you also have lateral you also have medial rotation. So yeah, I think that's safe to say. Yeah, you can assume that.
Okay, thanks.
Gotcha. Okay, so this is an image of the latissimus dorsi. Remember, again, he can test this. He can cover this this image and be like, what muscle is this? And you have to know that's the latissimus dorsi, right? This is going to be the latissimus dorsi. Remember, it attaches to the medial lip of the bicipital groove. Medial lip of the bicipital groove, latissimus dorsi. And remember, it's a happy muscle. Happy muscle meaning same sign, thoracodorsal artery as well as the thoracodorsal nerve. So here we go. So the arrow is pointing to a muscle. What is the arterial supply of that muscle? This is more, I would say, monthly style question. All right, so yes, the answer is D. Yes, A and C. So it's going to be the dorsal scapular artery as well as the transverse cervical artery. So yes, if you knew that this was the trapezius, you would tell yourself, okay, so I know the arterial supply of the trapezius has two arterial supplies, the dorsal scapular artery as well as the transverse cervical artery. Bam, then you got the question, right? So even though this is going to be the spinal accessory nerve, we're not talking about this right here. This is just, I guess, a distraction, but you just need to know that this is going to be the muscle, and you have to know the arterial supply of that muscle as well. So great job on that one. So next one, we're going to clump up into another category. We have the rhomboids, the levator, and then the serratices, which we'll talk about all in one. So when he talked about this slide, I thought it was a little bit confusing because the way it was written, it was kind of confusing about what was attaching to what and what was attaching to what. So I kind of made like another slide. So we'll skip this slide, but I'm going to grab the bullet points on the next slide and basically talking about it like one by one. So you really understand where the attachments of these certain muscles are. So I made this image for us, and these images are actually coming from Complete Anatomy, right? So you can see they're really clear images of these muscles, so we can really understand where their attachments are. So what first we're going to talk about is the rhomboid major, minor, and levator scapulae. So the rhomboid minor is above the rhomboid major, right? Or superior, let me just say. It's superior to the rhomboid major. So this would be the rhomboid minor, this would be the rhomboid major, and then this would be the levator scapulae, right? So this would be levator scapulae. It's also located right here, right? So the lateral attachment of all of these will be the vertebral border of the scapula. What I mean by that is this is the scapula, right? This entire bone right here. This is technically called the medial border or the vertebral border, same thing, of the scapula. You can see these three muscles, right, are going to attach to the same part of the scapula, which is why they say the lateral attachment is going to be the vertebral border of the scapula. That makes sense, right? The medial attachment for the rhomboids minor and major is actually going to be the spinous processes. Remember, the things that are going straight posterior of C to T. So cervical vertebrae to thoracic vertebrae. You don't need to know the numbers, just know it's C to T. While for the levator scapulae, it's a little bit different, which is why I added this image. The levator scapulae attaches to the transverse process. You see, it's actually attaching to the thing that's on the corner, on the side. The transverse process is things that are pointing outwards, right? It's actually going to be the transverse process, not the spinous process, right? These are going to connect to the spinous process, which is the same thing as the things that are coming posterior, right? The levator scapulae is going to connect to the transverse process, which is why I inputted that image, because I feel like it was very difficult to see that in this image. So I posted this image right here so you guys can really see that it's actually attaching to the transverse process. All right, so I hope that makes a little bit more sense on those muscles. So
I had a question.
Yeah.
Are those attachments, are those considered insertions or origins?
Yeah, so this would be, so for example, for the levator scapulae, this would be an origin, right? So this would be a proximal attachment, and then this would be an insertion, which would be a distal attachment. But he's not gonna ask which one is an origin and which one's an insertion. Remember, he's trying to avoid using those words. So proximal would be anything that's closer to the midline, so I'd be over here. Distal would be anything that's further from the midline.
Would medial attachment be synonymous then with the proximal, and then
Yes.
lateral attachment be synonymous with this? Okay.
Yeah, you can assume that, yes. All right, I hope those make sense, because I feel like the levator scapula is really hard to see if you didn't have an image like that. So again, you have the serratus. So the next ones are going to be the serratus posterior superior and then the serratus posterior inferior. The reason why they call this, obviously, so these are both serratus posterior because they're on the posterior side of your back, but one is called superior because it's on top, and one is called inferior because it's on the bottom. They're like accessory breathing muscles. They kind of help with breathing, not so much. I mean, they help a little bit, but your main breathing muscle is going to be your diaphragm. So the lateral attachment, like we said, this. Remember, when I put these things on the slides, these little columns things, these are exactly what he wrote on this slide. I just copied and pasted them onto different slides just to break them up to make them a little more digestible, right? So the lateral attachment is going to be the lateral ribs. You can see that, right? This is going to be the serratus posterior inferior attaching to the lateral ribs, right? Right here. Same thing with the serratus posterior superior. But remember, like I said, it kind of looks like it's attaching to the scapula, but it's not. This is why I posted this picture, which is a close-up. You can see that the serratus posterior superior attaches to the lateral ribs. You see, it's not the scapula. It actually attaches to the lateral ribs. So this doesn't do us too much justice, which is why I posted this image as well, just to give you a close-up view as to see that they both attach to the lateral ribs. The medial attachment is going to be the spinous process C to T. That makes sense, right, for the superior one, because cervical vertebrae to thoracic. So what would this have to be? This would have to be thoracic to lumbar because it's lower, right? So thoracic to lumbar. So those are going to be the attachments for those. So again, I just posted the pictures on one slide, helpful pics. Feel free to use them so you can identify these muscles. You can use the attachments. Yeah, so I just put them on one slide. I'll post them later on as well. So you're going to have a question. Yeah, of course.
Yeah, so I think in Complete Anatomy, the serratus muscles are described as intermediate, but in the PowerPoint, he has them as deep. Which one should we go by?
So he's honestly not going to ask you to like describe or like differentiate between which one of the superficial ones is most deep. Like just know that the serratus posterior, I mean, technically it probably would be deep because the trapezius is going to be the most superficial. Then the rhomboids would be the ones that are going to be intermediate, and then the serratus posterior inferior would be the ones that are deep, right? And then obviously you have your deep back muscles here, right? But those are just going to be like sub-attachments of superficial. You don't need to know, I think, the specific subcategories of those.
Thank you.
Got you. Okay, so I think of the rhomboids major, minor, and levator scapulae as another set of happy muscles, right? So again, remember when I say happy muscles, like muscles of the same sign, they're going to be the same thing. So again, we talked about latissimus dorsi. That's going to be thoracodorsal all the way. Thoracodorsal nerve, thoracodorsal artery, right? So for rhomboids major and minor, as well as levator scapulae, they're all going to be happy muscles. So when I mean happy muscles, I mean dorsal scapular artery as well as dorsal scapular nerve. So that's good. We can clump that into one and be like, all right, that's it. Anything that's going to be on the exam that says rhomboids or levator and they're asking for arterial supply or nerves, it's dorsal scapular no matter what, right? So that's helpful for us. It's going to be that. And then this is going to be, so again, I showed you the complete anatomy version of it. This is going to be the cadaver version of it, but you can see, like I said, it kind of looks like the complete anatomy one, right? This is going to be the rhomboids minor, which is superior to the rhomboids major, right? This is going to be rhomboids major, and this would be the levator scapular, right? So which is why he points it out right here, right? Levator scapular. Remember, he posted this image right here too, because remember, the levator scapular is going to attach to the transverse processes on the medial side, right? So the things that are pointing out on the side, this is why it's red right here. While the rhomboids major and minor attach to the spinous processes, you see? So it's a little bit different when it comes to the rhomboids as well as levator when they're talking about medial attachment. But the lateral attachments are the same, meaning it's going to be the vertebral border of the scapula, right? That makes sense. So this slide is kind of hard to study off of if you don't like really understand the arterial supply. But to understand, like we said, this like looks like as you like look at more cadaver pictures and more cadaver pictures, you'll be able to see and differentiate what's going to be arterial supply and which would be innervation. So you have the suprascapular nerve, which is right here. I mean, he didn't expand upon this too much, but I mean, we'll talk about it later in the rotator cuff muscles. This is going to innervate two of the rotator cuff muscles, which is the muscles in your shoulder. The dorsal scapular nerve, oh, we're like, okay, like you should be thinking, okay, dorsal scapular nerve, remember, this is part of our happy muscles. So, okay, so this is going to innervate the rhomboids major, the rhomboids minor, as well as the levator scapulae, right? So bam, if you start thinking like that, then you'll be able to remember that, okay, this dorsal scapula should be able to innervate all those three muscles. Long thoracic, we'll talk about that I think in the next couple lectures, but we don't talk about the serratus anterior too much, which is this muscle right here. It's also called the punching muscle because it helps you a lot, or like the boxer muscle, because it helps you a lot with protraction, so with throwing punches. But this is going to be the long thoracic nerve. We'll get more into this as we get into other lectures, but I would say study the slides after you have like understood like all the innervations and all the arterial supplies, because it's very difficult to point these out once you specifically on cadaveric images. So which muscle is not innervated by the dorsal scapular nerve? Okay, nice. Yes, it is D. It's going to be D because remember, the trapezius is going to be innervated by the spinal accessory nerve, cranial nerve 11. So again, I could have made this question a little bit harder. I could have said, which muscle is not supplied by the dorsal scapular artery? And again, all of these are supplied by the dorsal scapular artery, because if you remember from the trapezius picture, the trapezius is supplied by the dorsal scapular artery as well as the transverse cervical artery. So I could have made that a little bit more difficult and a little bit more trickier. But understand that just because it's dorsal scapular, you still have to remember that it's dorsal scapular nerve, because if I were to put artery, all of these are supplied by the dorsal scapular artery, right? Because remember, the trapezius actually has an arterial supply coming from the dorsal scapula as well. So remember, think about that. You still have to remember, like, just because it's, oh, this is dorsal scapula no matter what, you still have to remember that trapezius does have a dorsal scapular artery that supplies it, not the nerve though. Okay, so again, I made two summary slides. Some muscles of the same sign, whatever you want, are happy muscles, whatever you want to think about it. Latissimus dorsi, thoracodorsal all the way. So artery and nerve. You have the rhomboids major, minor, and levator scapular, dorsal scapular all the way. So it's going to be dorsal scapular artery and nerve. Muscle of a different sign, that's trapezius, because again, the spinal accessory is going to be cranial nerve 11, like we said, and you're going to have the arterial supply, which is going to be dorsal scapular artery, as well as the transverse cervical artery, which come off the subclavian, right? So, and again, we talked about the serratus posterior, superior, and inferior. We talked about these already, but this will just be the innervation as well as the arterial supply. So, yes, the rhomboids minor is superior to the rhomboids major. The reason why it's just called major is just because it's a larger muscle. So you have branches of the intercostal nerves, right? So branches of the intercostal nerves are going to innervate the serratus posterior. So that makes sense because look, it's near the ribs. These nerves are going to be right here, right in between the costals or the ribs, right? Intercostals. And you have the posterior intercostal arteries, which are going to supply the serratices. So I feel like this, that really helps if you know that the serratices are attached to the lateral ribs. you'll be able to remember that it's supplied by the intercostal nerves and the posterior intercostal arteries, right? So last one is going to be the deep back muscles. He barely emphasized on this, or he didn't talk about it too much, but I'll just hone in on the stuff that's going to be super high yield. Like he didn't talk about too much about the splenius capitis and cervicis, so I wouldn't worry too much about that. But what is important, 100% important, definitely testable, is that the dorsal primary rami is going to innervate the deep back muscles. Remember, D for D. Dorsal primary rami for deep back muscles, right? That's going to be 100% important. So I would definitely know that.
Justin, real quick question, because the way it looks on this image that he's pointing to is the splenius cervacis. It looks like he's almost pointing to the serratus posterior superior muscles, or is that like an overlapping type thing, or is the arrow at the wrong place?
So what he means by that is that the arrow is dashed. The reason why it's dashed is because it's actually below the serratus posterior superior. So you can't see it, but it's actually below it.
Thank you.
Or yeah, deep to it is what I mean. Okay, so that'll be that. He even said, like, don't worry about the branches of the rectus spinae. Like, I don't think you need to worry about iliocostalis, longissimus, or spinalis. Just know that the rectus spinae, as well as the transversal spinalis, are deep back muscles. I think that's the most you need to know about that. But again, remember, nerve supply or innervation is going to be the dorsal primary rami. So D for D, dorsal primary rami for deep back muscles. You won't forget it if you keep telling yourself that in that like specific way. So this is just flexion, extension, lateral bending, rotation. We know these. We can skip this slide. He didn't go too much into this because, I mean, the rectus spinae and the transversal spinalis don't, do too much extension. Yeah, they do extension, and yeah, some of these do some flexion, but most of the movement that you're doing about extension and flexion of your back is going to be movement at the hip joint, right? So I wouldn't spend too much time focusing, the rectus spinae does extension while the rectus abdominis is going to do flexion. And it's more so like the hip joint that's going to be doing most of those movements. Same thing with lateral bending. Like if you think about your abdominal obliques, which are going to be on the sides of your abs, that's obviously going to help you with lateral bending. But rotation, like we said, transversal spinalis, but I wouldn't go too much into like knowing the exact differences between these. And then again, same thing with this. The only thing you need to know is that I guess cervical vertebrae and thoracic vertebrae and lumbar vertebrae, each of their joints have different types of movements. I think that's as in-depth as you need to know. And that the facets, like we said, are going to allow for minimal movement. That's probably the most high yield out of all of these. So, and then you're also going to have, so he even said on this slide that the most important thing that he wants you guys to know is that the suboccipital triangle, what does he mean? So by minimal movement, he means that like the vertebrae aren't just going to slide off of each other. Like you said, they're like very tight knit. Like we said, they're going to allow for a little bit of movement of your vertebrae, so like you can like bend your back a little bit, but it's not going to allow you to just like slap a vertebrae off the next one, right? So it's not going to be like allowing you to like have unlimited movement in your vertebrae. That's what it means by that. That was an answer to the chat. Okay, so you have your vertebral artery, which is going to go through the suboccipital triangle. Did I put occipital triangle? Oh, I'll fix that. I meant suboccipital triangle, yeah. So suboccipital triangle, 100%, definitely testable. Like, I think he would definitely possibly ask an exam question on this. We know that the vertebral artery goes through two things. It goes through the transverse foramen of each cervical vertebrae, as well as the suboccipital triangle once it gets up into the cranial region or into the brain region, right? This will be the suboccipital triangle. I wouldn't go too much into depth knowing that C1, C2, and C3 are those corresponding nerves, but I would just say know this in blue. That's the most high yield. So you also have the ventral primary rami, which is going to be, like we said, that's going to go and branch off into a bunches of things. The ventral primary rami would be your brachial plexus, your cervical plexus, et cetera, right? But your dorsal primary rami, remember, D for D, dorsal primary rami for deep back muscles. 100% necessary to know that. And again, just like we said before, ventral primary rami becomes a lot of muscles. It becomes a lot of nerve plexuses. So, for example, your cervical, your brachial, your lumbar, and your sacral. But remember, it's important to note that you don't have a thoracic plexus, right? You have plexuses all over here, but you don't have a thoracic plexus. You don't have a thoracic plexus because all of these nerves that come from the spinal cord are going to go between the ribs, right? So they don't make like a plexus, meaning like a bunch of branches of nerves, right? It's just going to go in between the ribs, which is why they are called intercostal nerves and arteries, right? That would be that. So, and I inputted one more question in here just to put it in there because I wanted to put one more, and this will be the last question. So what is the innervation of this muscle? Yeah, the muscle that has the name on it. Yeah, the latissimus dorsi. Obviously, he would probably cover it, but I didn't want to cover it because then you would probably cover the entire muscle, and you won't be able to see it. Okay, so yes, it is D. It's going to be D. It's going to be the thoracodorsal. Remember the nerve. Remember the latissimus dorsi has a happy muscle, thoracodorsal nerve. So that's really important for us to know that. It's also going to be the thoracodorsal artery for its arterial supply. So that will be that for the lecture. So if you guys have any questions, please feel free to shoot me in right now. Let me know. I'm here to let you guys know, or here to answer anything you guys need. But that will be it for the lecture. So thank you guys for coming. Please feel free to ask questions now if you need to.
Hey, Justin, a couple people asked in the chat earlier, the kind of questions you're asking us now are more like level 1, kind of reiteration of what reading from the slide. Will you hold like separate quizzes on Canvas, or will the questions you ask during your TA sessions increase in difficulty?
Yeah, so the questions that I'm going to ask that are going to be specifically on the TA sessions are going to be much more difficult, I think. Yeah. So during the Friday session. So when you get those Fridays quizzes, I'm definitely going to ask like tougher questions.
Okay, so this is just like an intro easy question. All the rest of them should reflect the Muffley style questions of difficulty.
Yeah, so most of them, yes. But as we get on to more and more lectures, I might like throw in like harder questions. But this is like our first review, so I wanted to get you guys used to these questions, and eventually I'll probably make them more difficult as we go on.
Thank you.
You're welcome. Okay. Any other questions?
Was this session recorded?
Yes, but I'm not allowed to post it though, unfortunately. But I will be posting my PowerPoint though, so that should be able to help you guys a lot. And if you do have any other questions, feel free to send me your email. You do have it.
Hi, Justin.
Yes. Hello? Hello? Are you? I can't hear you. Did somebody ask a question?
Yeah, sorry. I think my computer's just being slow.
Oh, no, you're good. Hello? You could type your question in the chat if you want, because I can't hear you right now. But if you want to type it, I'll just read it and then I'll answer it, because I can't hear you right now.
A post that Samantha Bate asked in the chat was, when he posts cadaver photos on the exam, will there always be a zoomed out version so we can orient ourselves?
Most likely.
Okay, thank you.
Yeah, most likely he will, because it's going to be very hard for you to just a little square image and point out what nerve is this. So yeah, he most likely will put a zoom out picture as well.
Would you say that the majority of the exam questions are more clinically oriented or more picture oriented?
So last year, Muffley didn't put like much pictures on the exam, so there weren't too many pictures on last year's exam. But I definitely do think this year he has put a lot of cadaver pictures on the PowerPoint. So I would definitely focus on those pictures, because a lot of those I think will definitely come up on the exam. But I'm not too sure, because he didn't have cadavers last year pictures, because we went to the gross lab. So we went to the gross lab more often, so he didn't post those pictures on our PowerPoint. But since he's posting them this year, I would assume that he would put a decent amount of questions based off those pictures.
Thank you.
Mm-hmm. All right. Any other questions? Let's see. Feel free to like hop in right now and like just talk if you want.
Hi, can you hear me now?
Yes.
Okay, the questions from Dr. Barber in the morning that we get in those emails, are those to use for these study tools, or is that just kind of to get our brains thinking in the morning?
Yeah, I think it's kind of just to get your brains thinking in the morning. Last year, we would sometimes do the questions, but we would rarely see them on the exams. But this year, I'm not too sure, because things are a little bit different. So I would definitely look into those questions just a little bit, just to get your brain thinking. But I wouldn't focus too much on those. I would focus like heavily on just the PowerPoints. And if you do understand the PowerPoints, like you should be able to answer those questions regardless if you do see them on the exam.
Thank you.
Got you.
Hi, Justin. I have a quick question.
Yes.
For slide 51.
Okay, hold on.
What were you referring to for that one? You said remember the something for, I believe, cervical.
Let me see. So slide 51, what was on that slide? Because my slides are a little bit different.
Oh, it says back intrinsic movement of back. Facet joints allow for minimal movement between vertebra.
Okay, hold on.
There's a bunch of like orange squares.
Okay, hold on. So 51. Hold on. Okay, wait, say that again. So you said, what was the main picture on that PowerPoint?
There's just a bunch of orange boxes. It's like joint movement.
Okay, hold on.
It's the fourth one to the last one, so fourth to last.
Okay,
so if you go backwards.
Okay, give me 1 second. Sorry, it's because like my slides, I added more things, so it's a little bit more difficult to find the numbers. 1 second, hold on.
If you show me your screen and then if you go from the back, I'll. Yeah.
Oh, yes, perfect. Okay, I'll do that. Yeah, sounds good. Hold on. 1 second. Let's see. Hold on. Hold on. Dang, this is giving me trouble for some reason. Hold on. Okay, share screen. Okay, do you see it?
Yeah, I can see it. It's going to be, keep going up. Oh, no. I believe, yeah, oh, okay, way down.
Oh, way down, okay.
Yeah. Keep going. Right here. Past it. Go up. Yes, this one.
Okay.
So for this one, you said something, but I didn't write it down. You said something about cervical movement. Can you just reiterate that one again? Sorry.
Yeah, so the cervical, usually, the only thing you need to know about the slide is that the cervical, thoracic, and lumbar are just going to have different types of movements. So you can see in this image, it's just going to have the cervical will have like side to side, the thoracic will have like this up down kind of motion, and the lumbar will have this like kind of like front and back. But you don't need to know the specific movements of it. The only thing I would just need to know, is that they all have different types of movements when it comes into regarding their joints, and that the facets allow for minimal movement, meaning that they don't move too much, right?
Okay, perfect. Thank you, Justin.
You're welcome. Okay. Any other questions? Feel free to just hop on in.
Hi, Justin. I have a question about how you specifically studied for this class when you were in the program. So you said that you talked over the lecture with your friends, but like, what would you do after that?
So what I would usually do, I studied a little bit differently, but I would like I said, I would go through the material once, like just talk it out just to make sure I understand what's going on in the lecture. And then I would actually go by myself and I would talk it out again, but like I would try to not like look at the slides. I would try to just be like, all right, this is latissimus dorsi. Okay, so we're gonna talk about latissimus dorsi this entire like 10 slides, and I'm just gonna try and spit it all out without having to look at any single slide. And then if I missed anything, I would go through the slides and be like, okay, this is what I forgot. So that's the way I kind of studied, was like trying to make sure that I can reiterate stuff and understand what's going on without having to look at it. But a lot of other people study a little bit differently because they like to use like Anki cards and flashcards and other things like that. So I would definitely try all the different types of study styles. That's the best study style that worked for me because I felt like talking it out was very fast. I didn't have to write down because writing took me a very long time. So I would talk things out, and if I didn't understand it, I would just look at it again and then go through it again. So that was my personal writing style or personal learning style. But for other people, it was like flashcards, Anki, etc. So I would definitely try out multiple ones to see which one you feel like fit best. But that was my personal preference. And complete anatomy as well. That really definitely helped me a lot.
Okay, thanks.
Gotcha.
Justin,
Yep.
can you hear me?
Yes.
Can you keep posting the complete anatomy pictures if you don't mind, because they were really helpful.
Okay, so you want me to incorporate those more in the later PowerPoints, like for the later lectures?
Yeah, it was really clear, much clearer than the ones Muffley posted.
I got you. Yeah, so that's why I screenshotted some of them on my phone and then I put it on PowerPoint. So thanks for the advice. I'll make sure to put more of those on the PowerPoint as we go through on the course.
Okay, thank you.
Yeah, for sure. Oh yeah, let me know, guys, if you need, like, if you feel like if you want me to do anything else more, if anything was helpful or not helpful, like, let me know. Like, I'm here to work with you guys. I want to make this as engaging, as helpful as possible. So tell me what I'm doing wrong, or like whatever you need help with. I'm like open to criticism or whatever. I want to make sure you guys are doing really well.
Well, I like the way you made your sides more digestible, as in there was like the innervation, blood supply, and all the muscles were like grouped more like you would do in a table. So that was really good. A lot better than what we got, or what I got from Dr. Muffley's lectures.
Yeah, so that's what I'm trying to do during these TA sessions, to make sure everything, like I said before, I'm trying to make this as digestible as possible. Anatomy definitely is very complex, so I'm going to try and make it as simple and as concise as possible. So thank you. More quizzes.
Tips on studying the muscles?
So what do you mean in regards to like their innervation, like what do you mean, like their attachments, like everything about them?
Yeah, everything.
So first of all, like with the muscles, like I would use the pictures that Muffley has. If they're not helpful, I would go on another website or use Complete Anatomy to really picture yourself on like where the muscle actually is. Once you see it visually, all the attachments make perfect sense, right? Like as I go throughout the PowerPoint, like these proximal attachments make sense, these distal attachments, but it's just really about getting the right picture and image to see it. Once you see the muscle and understand it, then you got to start memorizing the innervation and arterial supply, right? So those are going to be the second most important things you have to know about the muscle. The third most important thing is you have to be able to identify it on a cadaver, because he's putting a lot of cadaver pictures on there. If he has an image on it, you have to be able to